Medical Association who got the idea of this university, and with this I thank you all for your patient hearing. Now I should request Dr. Arulraj to give his speech on this aspect.
May I request Mr. Rao, who is the main technical architect team's head, who has created this online university, to come over and express his words, how he was able to put medicine. They have the total undergraduate and postgraduate things online. A few words of his experience will always highlight the significance of this event. Please, Mr. Rao.
Yeah, the company I represent has been a forerunner in the use of ICT to teach medicine. So we operate at a point of intersection between technology, medicine, and education. The genesis of the company was in the context of endemic shortages of faculty and an inability to increase the supply of doctors in many parts of the world. So what we really tried doing in India in this company in Hyderabad is to capture over 5,000 lectures by the leading faculty of India, then enhance that content in various ways by using animations and PowerPoints and videos of one kind or the other, illustrations and so forth, and tighten that and make sure that it was an effective supplement to faculty-led instruction in classrooms. When integrated with skills labs, when also integrated with ICT content that is brought live from operating theaters or from ICUs or from consulting areas, we figured that this was a very effective substitute to the kind of instruction that more orthodox ways of teaching would demand. And we signed a principled long-term agreement with the Indian Medical Association a year and a half ago to see how we could possibly promote online education coupled with hospital rotations and mentorship programs. The more you think about how those equations can be designed and managed from the back end, the more you see how effective teaching can be, especially for general practitioners and family physicians who are denied the possibility, living in those 600 odd small towns and districts of India, there is no way to upgrade that knowledge base. And that's probably true of many parts of the world, because unless you're a specialist and you just happen to have a small two-room shop somewhere in the corner of the world, there's simply no way that you can upgrade yourself from time to time, and the self-confidence depletes and your ability to handle cases that you've been originally trained for in college diminishes. So that's what we attempted to do. We are very proud that we have an opportunity to work with the Commonwealth Medical Association, and we hope to be able to scale this to over 50 odd countries. My colleagues in the Dr. Leela and Srinivas are here, and such as those who have an interest in understanding this a little bit further are very welcome to do so. Thank you very much.
I would like to now invite Dr. Arulraj to launch the website of the university, and I think the AV team is ready for that.
The third sign which would indicate a sick neonate is presence of seizures. What are seizures? Seizures are abnormal movements of either the whole body or part of a body. It could be one limb, it could be both upper limbs, it could be all four limbs, it could be one side of the body. Seizures can involve any part of the body, or they could only be localized to the face. So any part of
Ladies and gentlemen, it's really a proud moment for all of us in the 54 Commonwealth countries wherein Sri Lanka falls under the Central Asian group along with India. With the leaders here, it's my proud privilege to launch this important online learning system for the Commonwealth Medical Association. I should really thank Dr. Vajra for this event and for the nice introduction he gave about you. But he didn't say anything about him. The Commonwealth Medical Association chair or the leadership comes to Sri Lanka next year by the same time, probably in the same venue. The presidency of Commonwealth is 62 years old. It started from Sri Lanka. Most of you may know Dr. Preeti Vijay Gunavarthane. He is a GP, very senior GP in Sri Lanka. His father was the first president of Commonwealth Medical Association. I am the previous president from Central Asia. Now the current Vice President Vijay Kumar is here. The incoming, rather the future President of Commonwealth Medical Association, can you all make a guess? This man, this great man, your Sri Lankan Medical Association has given him as the President. In 2016, same cinnamon grand, on the probably same podium, we may install him as the President of Commonwealth Medical Association. The pride and the privilege of Commonwealth Medical Association that has been put on a red carpet for him is this Commonwealth Medical University. With great pleasure, let me launch this. Coming? Yes. And Mr. Rao was explained to all of you why this has come, this and that. But I would like to briefly say a few words about it. Knowledge and skills are part of the medical professionals. You can't separate it. Knowledge alone cannot do. You may have a qualification, but you may not do well on the patient. You may have a skill, but you may not have a qualification. Both are needed, twin. Both are bound very much. Then only we will be able to satisfy the expectation of today's citizen, any country, all the 54 countries, what is they expect. And we can go to a medical school, but how many of you are able to get a seat there? That's a major issue that drove me to this idea that why not we have an online system. There are all other disciplines, they have it, why not medicine? We have today virtual medical schools in United States of America, virtual dental schools available in United Kingdom, wherein Commonwealth Medical Association headquarters is there. But today the major issue is skills component. Knowledge component or theory component, fine, skill component. I am extremely thankful to the medicine system. Dr. Leela, can you have an example here that you can put it here? See, they have combined skills with knowledge.
involved. In neonates, usually it is focal seizures or partial seizures and less likely to be generalized for the reasons of growth, because the central nervous system is not yet fully myelinated. The baby generally does not have full-blown generalized seizures. They are more likely to have partial seizures of any part of the body, or they can even have something called subtle seizures. Subtle seizures are seizures which are not evident as seizures. They may be appearing as normal movements, but which are being done repetitively, in a repetitive fashion over a period of time. For few seconds or minute, a baby is going on doing. And what can be the manifestation of subtle seizures? The subtle seizures can be manifested as lip smacking movements. A baby may be doing, that would be the lip smacking movements, or constant fluttering of the eyes, constant, not just periodic, but constant fluttering of the eyes,
As Vajra was telling, initially we will start with, we are opening up on November 1st with the CPD programs. There are 350.
I said that the terminal part, that is the tail of the pancreas, is related to the spleen, hilum of the spleen. So while removing the spleen, what we call as splenectomy, one must take care of the tail of the pancreas. Tail of the pancreas is rich in islets of Langerhans. So the moment you remove or you cause damage to the tail of the pancreas, what happens is he will have diabetes mellitus. So you must know, one must take care of tail of pancreas while removing the spleen, splenectomy. I said that the terminal part, that is the tail of the pancreas, is related to the spleen, hilum of the spleen. So while removing the spleen, what we call as splenectomy, one must take care of the tail of the pancreas. Tail of the pancreas is rich in islets of Langerhans. So the moment you remove or you cause damage to the tail of the pancreas, what happens is
the next most important genodermatosis is the xeroderma pigmentosus. It is an autosomal recessive which is associated with the repair defect of the ultraviolet induced DNA damage. The child is normal at birth, but the diagnosis is suspected when a child has photophobia and freckling before the age of 2 years. We also have one more entity called as pigmented xerodermoid, in which the DNA repair is normal but the synthesis is decreased on exposure to sunlight. So early diagnosis and protection from the UV rays will prevent the cutaneous changes in the xeroderma pigmentosa patient. And these are the patients who have a high chances of developing the squamous cell or basal cell carcinoma in future. So early diagnosis and by taking the early precautions, it helps in the cancer surveillance. So this is a child who is suffering with xeroderma pigmentosa. Here we can see the presence of freckles and depigmented macules on the face. So such cases should always be evaluated cytogenetically and a repair gene analysis should be confirmed. So here the ultraviolet ray exposure of the cultured chromosomes will show the radial figures. So the prenatal diagnosis by the assessment of UV induced, that is ultraviolet induced DNA repair synthesis from the cultured amniocytes or a chorionic villi is possible. So this is one of the picture, that is the radial figures and the breaks which are shown with the red arrows, which will indicate that the patient is having an ultraviolet induced skin damage, and it also helps us in educating the patient about the sun protection and also the monitoring for future squamous cell carcinoma. The next most important genodermatosis is the xeroderma pigmentosus. It is an autosomal recessive which is associated with the repair defect of the ultraviolet induced DNA damage. The child is normal at birth, but the diagnosis is suspected when a child has photophobia and freckling before the age of 2 years. We also have one more entity called as pigmented xerodermoid, in which the DNA repair is normal but the synthesis is decreased on exposure to sunlight. So early diagnosis and protection from the UV rays will prevent the cutaneous changes in the xeroderma pigmentosa patient. And these are the patients who have a high chances of developing the squamous cell or basal cell carcinoma in future. So early diagnosis
lasting a few seconds, or even chewing movements, just persistent chewing movements. So these would be evidence of subtle seizures which are important to be picked up by a careful examination of the baby. So seizures is another important indicator of sickness in a baby. The third sign which would indicate a sick neonate is presence of seizures. What are seizures? Seizures are abnormal movements of either the whole body or part of a body. It could be one limb, it could be both upper limbs, it could be all four limbs, it could be one side of the body. Seizures can involve any part of the body, or they could only be localized to the face. So any part of the body can be involved. In neonates, usually it is focal seizures or partial seizure and less likely to be generalized for the reasons of growth, because the central nervous system is not yet fully myelinated. The baby generally does not have full blown generalized seizures. They are more likely to have partial seizures of any part of the body, or they can even have something called subtle seizures. Subtle seizures are seizures which are not evident as seizures. They may be appearing as normal movements, but which are being done repetitively in a repetitive fashion over a period of time. For a few seconds or minute, a baby is going on doing. And what can be the manifestation of subtle seizures? The subtle seizures can be manifested as lip smacking movements. A baby may be doing, that would be the lip smacking movements, or constant fluttering of the eyes, constant, not just periodic, but constant fluttering of the eyes, a staring look lasting a few seconds, or even chewing movements, just persistent chewing movements. So these would be evidence of subtle seizures, which are important to be picked up by a careful examination of the baby. So seizures is another important indicator of sickness in a baby. Third sign which would indicate
වැඩක් කිව්ව නේද මට කෝල් කළේ මට සුද්ධ කරන්න මොකෝ කළේ
හරි මේවා කරගත්තා එක්කෙනෙක් අර අල්ලගෙන කැපුවා
පින්නන්දුනා හොඳ හැද වයර්ක දිග ඇති වෙයිද
පොඩේ අන්න ඕක දාන්න වෙනවා අර බබල් එක ගාවට
පැටල ඒක මෙහාට ගන්න
මල් මේ එන්නකෝ
මට දෙන්නේ අවුට් එකනේ. මගෙන් ඉන්න එක කොහෙටද ගහන්නේ? මේකෙන් ඉන්න එක ගන්නවා නේ. හරි. ඕක අවුට් එක ගලවන්න පොඩ්ඩක් මට දෙන්න. ඒක මට දෙන්නකෝ. ඕකේ. අර පොත්තට ගහන්න මේක ගහන්නකෝ අර ජැකට් ගහලා දැන් දිග තියෙනවනේ. ඕක ගිහිල්ලා ඔය අර ස්පීකර් එක උඩින් තියන්න ලස්සනට වැටෙන්නේ නැති. මේන් ස්පීකර් එක උඩින්. මයික් එක. ඔව් අරක. වදිනවනේ ජැක් එක හොඳට. දැන් බූත් එකක් තියෙනවා. ඔව් කොහොනේ තියෙන්නේ මේක ගහන්නනේ. නෑ. කොහොම? දැන් අනිත් පැත්තට ගහන්න තියෙන්නේ. දැන් මේකට පොඩ මේක ගලවලා මේක ගහන්නකෝ අරකට ගහන්නකෝ. ඒකට ගහුවා. මේක ගහන්න ඔකට. අනිත් පැත්ත. අර පොඩක් දික් කර ගන්න ඕනේ වගේ. මයික් එක හරිද දැන්? හරි. මේක පැත්ත සයිඩ් එකකින් ඉන්නත් සයිඩ් එකෙන් එල්ලන්නකෝ. නෑ දිග ඇති. ඇති. දැන් දිග ඇති. දිගෙන් ගත්තා. නෑ දික් කළා. වයරක දික් කළා. කකුල පැටලුන ගමන් ගැලවිලා යනවා. ඉතින් දාන්න.
when the initiatives were started from individual interest, as it is seen in such situations, only the initiatives which are time tested, feasible and affordable were retained. These initiatives were later absorbed into the health system by the Ministry of Health or provincial ministries of health. And I like to say that ICTA has also taken up some initiatives and developed them, and helped in sustaining those systems. When we look at the eHealth initiatives, they can be mainly divided into hospital-based initiatives and preventive healthcare initiatives. As there are many initiatives, I may not take the time to describe all, but I'll make some general statements on things. Hospital-based initiatives were tried out at different times by the Ministry of Health and by other organizations. Most of the initiatives in the past were, based on individual interest, and when they have gone on transfers, so when they were not in the institutions, those systems failed. But currently we are seeing many sustainable initiatives, and these initiatives were mainly in the outpatient departments, medical records department, drugs management, inventory management, management of supportive services like laboratory and radiological departments. I like to talk about only a few of them. Although we tried several times to have the inward care into eHealth initiatives, it was not much successful because we have a high patient load and high workload with less human resources. So for the time being, those don't seem to be very realistic. But currently we have some renal disease surveillance and ICU surveillance systems which were running well. EIMMR was introduced to improve the medical records keeping. In the previous manual system, once the EMMR register was maintained for a quarter, the quarterly report was compiled and the provincial institution sent this data to the regional director of health services and then to the medical statistics unit. The line ministry sends this report directly to the MSU. Once this report is generated at institution level, there is repeat entry of data at RDHS and MSU level. With the introduction of eHealth initiative, the accuracy of these records and the timeliness has improved. As this initiative needs only a computer and an internet connection, and as trained staff is already available, we can train them. We were able to introduce this in 2 years into island-wide implementation. 40% of the curative care institutions have implemented this and are sending reports regularly. Now we are having various hospital information management systems, and our plan is to incorporate this into those systems once these systems are implemented in those institutions. One challenge in this initiative is, as only the number of hospital admissions were considered, it was not possible to assess the actual disease burden. The need of an unique health identifier to identify a person was discussed for a long time, and finally we have agreed on a personal health number. The institutions where eHealth initiatives are implemented, the personal health number is introduced on registration, and it is heartening to note that patients bring the personal health number when they subsequently visit the healthcare institutions. With the introduction of the web-based immunization system called the VBIS, in which all children were enrolled in the system at birth and the PHN is given at birth, action will be taken to print a space for PHN in the CHDR. As 99% of children are born in hospitals, gradually the whole population will have a PHN. One objective of the PHN is to ensure continuity of care and updating of medical records of a person from wherever he or she takes treatment. Whether the PHN will work when a patient goes to another hospital is still untested. Mostly we issue the PHN in one station and that patient comes regularly to that place. So we have to test whether it works when the patient goes to another hospital. We are planning a project in which a cluster of hospitals will be tested with this personal health number. A master patient index also will be developed for this purpose. We have mainly two hospital management information systems. As the time is running and I see them, there will be presentations on them. So I will briefly introduce the HMIS system developed by the Ministry of Health. Groundwork for the HIMS was started in 2012 at the National Cancer Institute Maharagama with the technical collaboration of the University of Kelaniya. And during this initiative, development of the initiative, continuous dialogue with the end user during development and training was carried out and the product was customized. We have still not completed this and some modules are running at the National Cancer Institute, Castle Street Hospital, TH Peradeniya, Gampala, Mahatala and Kurunegala. As there is another hospital information system also, it is very important that we develop interoperability of this system so we can harmonize the information needs. Considering various e-health initiatives taking place in the ministry has taken action to develop guidelines and standards with a view of streamlining the implementation of the e-health solution. Standards address mainly the following main areas: architectural model, management of hardware and software for the delivery services, network and connectivity, communication interface, privacy. Document as a whole has already been adopted. For instance, internal circular to streamline the domain name structure within the MOH is issued. Also, we have issued an internal circular requesting all the eHealth solutions implemented in the Ministry of Health to be registered centrally. This would pave the way for a software registry in the future. Also, personal health number is now being adopted in almost all the HIMS solutions implemented and piloted in the health sector. One of the key governing factors in relation to health systems is policies and strategies giving clear direction. Health Information Unit of Ministry of Health was able to take steps to form policy directions and related strategies for health information and e-health through the involvement of multiple stakeholders and numerous deliberations in this regard. The draft policy deals with key areas and related issues of information resources, data and information management, security, privacy and ethical considerations. It encourages information system automation with appropriate technology, ensuring interoperability of systems and encouraging data information sharing. Ethical and privacy considerations related to personally identifiable health information, especially in the electronic form, is given clear directives. Type strategies will ensure accurate data, evidence-based decision making in health planning, monitoring and patient care. When we look at the e-health initiatives, at a glance, we have several strengths. We have high computer literacy rate, in the younger population mainly, but the others are also can be trained because of their literacy rate. So we have ground level staff. We don't have the high level, staff to develop the systems. But if we have a system, you know, we can maintain it. And also, uh, we have the strength in having this MO health informatics. You know, they have MSc in health informatics, but we are trying to go for MD also. So they they are always there to give the leadership, and it's a strength for our system. Also, now there is a move to move the whole country towards e-health initiatives. So that also encourages us and also leads us in this way. But we have several problems if we are to initiate e-health initiatives in the health sector. The first one is if we have several systems, the need to train staff comes, especially as there are a high turnover of medical officers and so on, that this training needs comes very big. And also e-health is not, very cheap. The cost of initiatives must be very clearly considered. Even if we think of giving one computer and an internet connection, at the end it will be more than 100 million or so when we consider the whole country. So this cost is a problem we have to consider, and also that makes us to think of what are the suitable, most efficient systems for our country. And also network connectivity is not there at all places, but we have gone to several seminars where ICTA is trying to initiate various new techniques for improving connectivity. So we hope with time this will be addressed. Thank you very much. Yeah.
Thank you, madam, for your very informative and elaborating lecture. As the chief person or chief contact person for the e-health initiatives in the health ministry, I think you have covered almost all the areas regarding the implementation of e-health solutions and what are the our strengths, weaknesses, or the challenges we face, and also most importantly regarding the ROI or the return of investment on e-health solutions. So as we are running short of time and somewhat behind the schedule, if there are any questions, your questions are most welcome, and Dr. Champika will be able to answer the questions. Actually, the most important thing is what we need is health policy or the health information policy for the country. I know that you are working on this. So what is the current progress of this?
Actually, maybe we need to have a final stakeholder discussion, and then we'll be able to take it to the cabinet. We are waiting for the date from the DG for a final stakeholder meeting.
The HIM system that has been implemented since 2012 in development, is that going to be used across all the hospitals or in certain areas? Okay. The system that's been developed, is that going to be used across all the hospitals? The HIMS system?
Any more questions?
Actually, we have started training the private hospitals also. When they request for ICT training and all, we are providing the training now. So gradually, we want them to, provide the information needs and also to get their information. This is especially important because the private sector is also growing, and uh, earlier it is not a problem when 95% of the morbidity, data we get from the government hospitals. But now with the increase in the private sector, we are definitely interested in including them also in our systems. Yeah, yeah. Actually, we have our regulatory authority in the private health sector, regulatory authority, and they are also trying their best to link all the private hospitals. So we'll include them also in our loop, and with them we'll try to develop them.
Thank you very much for your participation. Ladies and gentlemen, that concludes the plenary. The next parallel sessions will commence in, we'll hope to commence them in another 5 minutes time once the halls are arranged. You may check the program book and attend the parallel session of your choice. සමහර අය වගේ ෆෝල්ට් එක දෙනවා.
Good afternoon, ladies and gentlemen. I welcome you all to the second parallel session of today's eHealth Asia conference. This symposia contains 4 interesting lectures of these professionals who are very competent in their own fields. And I would like to remind you to keep your mobile phones silent and to help to maintain the silence in this room as some lectures are being recorded live. It's my pleasure to introduce Dr. Chaminda Veerabhadana and Dr. Saminda Dharmaratna to chair this session. Over to you, sir.
Good afternoon. Welcome to the parallel session, second parallel session, Key e-health initiatives of the National Health System of Sri Lanka. And this session we have 4 speakers and the allocated time is 1 hour. And we are already 8 minutes late. So please stick to take 10 minutes maximum. And there's a special request from the first speaker that we take the questions right after the presentation. The others will wait till the end of the all 4 presentations are completed. First speaker in this session is Dr. Sampath Kulatilaka, and he is presenting on e-hospital Dompe and M-channeling. Sampath Kulatilaka, MBBS, certificate in health program management, is a medical officer in charge of e-hospital Dompe project at the district hospital of Dompe, Sri Lanka. I invite Dr. Kulatilaka.
Good afternoon, ladies and gentlemen. I'm going to present few slides on e-hospital Dompe and what we have done at Dompe. I think there's some out of focusing problem is going on. Still, I will proceed with the presentation. This project is awarded as Sri Lanka's Best E-Content Award and National Award for Science and Technology Achievements in 2014. This is our hospital, 102 beds, divisional hospital in Sri Lanka. Have been networked, and doctor sweeps the barcode and get the medical histories, all the medical details of the patient within seconds. Then the doctor is doing the medical examination, routine medical examination. Then she is going to enter all these things into the computer and send the patient to the relevant service point. This is our dispensary. The patient is going to the dispensary with the barcoded patient health card. By the time the prescription has arrived to the dispensary, when barcode shipping, the dispenser will get the electronic prescription and the drugs will be dispensed. We have done this project for last 4 years. We are celebrating our 4th birthday on 27th December 2015 this year. As an extension to e-hospital Dompe, Sri Lanka's first ever free automated appointment system has been launched in Dompe in 2013. It's a free appointment system, free service. Our hotline is 0711 370 370. It's a private public sector partnership. It is guided by Ministry of Health Western Province. It is coordinated by Task Force on IT under Presidential Secretariat, facilitated by ICTA and powered by Mobitel. This is the M-channeling process. This diagram shows the M-channeling process, but it is a bit arbitrary, but the appointment system is not that arbitrary. The patient has to call to the hotline number, follow the voice IVR, ඔබ කැමති අංකය තෝරගන්න, ඔබ කැමති දිනේ තෝරගන්න, like it will going on, and by the confirmation he will be getting a SMS to his mobile phone. And when the patient comes to our hospital with the SMS, he will be our reception desk people will be checking the validity of the SMS and giving a priority card and giving a priority service at dispensary and doctor at the doctor and the dispensary also. In the administrative purposes, the available appointments availability will be done by the hospital system administrator, and arranging a doctor for M-channeling will be done by the hospital administration. A special M-channeling counter has been made for M-channeling people. What we are doing at Dompe is we are using the staff counter for that. This is the M-channeling web interface. The available slots shows in green color, reserved one in blue, and not available one in red. This is the M-channeling counter. Our nursing officer is checking the validity of the SMS with the live web interface. This is the priority card given to the patient. This is the M-channeling doctor's workstation. It has been modified to facilitate the doctor to cater M-channeling appointments. And this is the special M-channeling counter. In the implementation, what we have done, we have signed a MOU with the Secretary Health of Western Province and Presidential Office and the relevant hospital, and we had to arrange the hospital process flow for the M-channeling processes, and we trained our users for using the M-channeling web interface and giving the priority card and collecting the priority card at the end of the service. Then we made the propaganda through patient health card, campaign on announcements, and public awareness system of the hospital has been used to give the maximum publicity on this M-channeling process. This is how we did the marketing. This is the entrance board at our hospital. This is how we shows that we are giving a priority to the M-channeling patients, and this is at our OPD waiting area. We are giving publicity to use more M-channeling appointments. In the special points, the patients can reserve appointments for next 7 days. The patient has to bear only the call charge only. There's no cost behind or no channeling fee. One phone number will get only 2 appointments per day. The phone used to reserve the appointments, preferably a mobile phone, but can use even the land phone. Each appointment contains 15 minutes, and privilege to open or not to open appointments is with the hospital authority. There's no power in hosting agent. The medical officer in charge will receive a SMS showing the details of reserved appointments and email also. The patient has to register in the hospital HHIMS system at the entrance of the hospital. This is the SMS getting to the administrator at the hospital, and the email is also shown in the picture. We launched it on 5th November 2013 at Dompe Hospital, and we are successfully running on for 2 years by now. It will GIS, Government Information Center, and we want to develop a M-channeling mobile app for this for the easiness of the patient. This is how patients see on right. This was the end of my story. Thank you all for your kind attention.
Thank you, Dr. Kulatilaka. We'll take two questions in the interest of time. Then we'll have to, we can let you go. Any questions from the audience?
Yes. In this solution, there's no cancellation policy. Yes, I accept that. But usually, these are privilege given to our citizens. Therefore, there's very little occasions we have seen that they are misusing it. If they have put that appointment, they are used to come. I think about less than 5% is wasted with this. And I also accept there should be a cancellation policy. Definitely.
One more question.
Yes, we have started it at Damadani about by now, and we have thought of deploying it. The Western Police Health Ministry has get a policy decision that all the hospitals, e-hospitals, computerized hospitals should get M-channeling as a mandatory one. Therefore, Abhisavela and Panadura will nearly is they are now they are on training on M-channeling, and they will be starting that one. When the e-hospital concept going through the country, this M-channeling will be following. For sure.
Okay, we'll move on to the other presentations. Thank you, Dr. Sampath Kuladilaka.
Thank you. Thank you so much.
So our next speaker is Dr. Samantha Ranasinghe. He is the Deputy Medical Superintendent at Base Hospital, Panadura. His topic will be improvement of outpatient services in a base hospital through an interoperable information system, a case study. Over to you, Dr. Samantha Ranasinghe.
Good afternoon, ladies and gentlemen. It's a similar setting as Dompe. So actually, this was in base hospital Panadura, and our it's not like Dompe. Excuse me. So it's a big hospital with a bed strength of 320, and the outpatients average is 1220, but it's range from 1000 to 1800 per day. And also we have clinic attendance 525, and bed occupancy rate is 86%, and the staff is around 750. So first we thought it was a very crowded OPD in Panadura, so we were looking for solution. So we heard about this e-dompe. So we had a chat with Dr. Sampath, and also with the help of ICTA, we try to implement this uh, uh, HHIM system. And I don't want to waste any time. It's a similar software that we use. So our objective here was to understand how to implement HIS system in a base hospital, because we had a lot of problems when implementing. It was a retrospective cross-sectional study, and we did some quantitative and qualitative techniques. And this project was funded by Western Province, and it's nearly around 6 million. Uh, and the biggest problem we had now, Dompe is a district hospital. Our setting is a base hospital. So our patient turnover is around 1,200 to 1,300 per day. So there are a lot of units like nebulization, immunization, and dressings. So we have to design all the system. So we took long time to plan our system. It took around 1 year for background planning and infrastructure development. And this project was started with laying out fiber optic cables, and then gradually installs hardware and then software. And we had a problem of data security, because a lot of patients' data is stored in the system. So we had a plan of it has automatically copied DVD system, and there's a duplicate DVD stored outside the hospital in a case of fire. So we are thinking further to put the data into cloud. So I will give some pictorial description, and this was the after implementation. And as Dr. Sampath said, this was a first registration counter, and we we have several computers, not like Dompe, because our crowd is too large, and we have to put several points of computers to register patient and also give queue numbers. We have this is the health card given. This is a barcode thermal printer. So the thermal is disappearing with the time. So we have introduced a sticker instead of this thermal printer, which is durable. So we have a queuing system like telecom, not like Dompe. We have a separate queuing system like telecom. When the patients come, they take the number and then consult the doctors, because at a time there are about several doctors, about 6 to 10 doctors. In Dompe, only two doctors or 3 doctors seeing at a time. So this system has to be we upgraded, and we developed this queuing system. And these are some pictures, and these are the queuing displayed at to see the patients, and it's like telecom teleshop. And I don't have to explain these things, because Sampath has already explained. The patient data is entered, and this medical officer is taking the data of the patient's their name, age, sex, and residence area. So the second visits also, they will have this card, and the data is in the system. Right. And this is in the dispensary also we had a lot of patients. So we have to have about 3-4 counters for dispensing drugs. So these are the dispensers who dispense in drugs. And this was the scenario before and after. And we done some satisfactory surveys, and the patients were more than 90% satisfactory, and staff also more than 90% satisfied with the system. And waiting time, it has reduced drastically, and patients, they said the system is very quick. And the system is running for one year, not like Dompe, they have run for 4 years, but our system is 1 year. But during the running, we also have some problems experience, and we are trying to solve those problems. We can share with you. And this is the dispensary. Earlier it was a busy dispensary. Now the queue system is there, and patients are getting their drugs immediately. And we have employed some staff in minor categories. Minor category staff, they are trained and they can do the job, and they are very satisfied. And the advantages has since there are a lot of data was gathering and lot of documentation, it is reduced now because it is computer based, not papers. So the storing facilities is now we don't have to worry about the storing facilities, and administrative facilities also has been increased because we have several access levels. The medical superintendent can access every levels, and he can see when the doctors come and how many hours they have worked, and how many drugs dispensed, and all the data is included. And problem we encountered because of this large crowd, there was a busy registration counter, and self token was given, and we have improved a queuing system, and these are some problems we encountered. And we have developed a self token system that easy, because you have to put the barcode, and then automatically the queue number is coming. And we have done some new innovations. We have in the office also some documents are sent through the email system and SMS, and our clinical meetings are uploaded to the Facebook, and any lectures can be downloaded. And we have satisfactory survey through the SMS, and call assisted appointment, especially M-channeling, Dr. Sampath said, but it's designed by our people, and it's not through a Mobitel or other company. And this is user friendly, and no need personal or mobile phones, and no need additional hardware or internet facilities, and cost is minimal. And recently we have developed this video conferencing, which we can give lectures and receive lectures from any other country or any in Sri Lanka. These are some interventions that new interventions that we have done. And I would like to thank Dr. Deepthi, Provincial Director, and Dr. Amal Harsh De Silva, and Mr. Rodrigo, and Dr. Uday Ratnayaka, and Dr. P.R. Samveda, and Dr. Sarath Samarage, and especially for giving this opportunity, Professor Ajay Sinaratna and Dr. Roshan Hemapatana. Thank you.
Thank you, Dr. Rana Singh. We'll open the floor for questions once all these presenters have presented their presentation. So,
next speaker is Dr. Nishan Sirivardhana on developing and implementing a hospital information management system. He works at as a medical officer, health informatics at the research health information and research unit at the National Cancer Institute. He is the project manager for the National Health Information Management System (HIMS) developed by the Ministry of Health, Sri Lanka. He has worked as a clinician and a medical administrator in curative and preventive sectors at the Ministry of Health. Uh, his research interests are HIMS development, telemedicine, cancer prevention, and quality improvement in health sector. Over to you, Dr. Nishan.
Thank you very much for the kind introduction, Shaminder. Now, today I'll speak on the how we develop this hospital information management system and what was the idea behind all this exercise. Now, the content of the presentation is why we developed this and what is the advantage of homegrown solution and the implementation and maintenance plan for the next years. Now, as any hospital information management system, our system has all the other modules like patient registration, patient admission, patient discharge. On top of that, we can add ward admissions, labs, radiology, ward discharge, and we can communicate with our EIMR system to for greater interoperability, and we can maintain electronic BHT as well as the e-pharmacy. Now, to make sure our system operates seamlessly with other initiatives in the ministry, we are issuing a personal health care number based on the formula proposed by the ministry, and it's given in a barcode manner, and that can be used in any other hospital where compatible systems are running. And this is the exact formula prescribed by the ministry for this PHN system. Now, once you admit the patient to the ward, the doctor can perform many activities like ordering lab investigation, radiology investigations, and e-prescription. And at the lab, again, you can do sample collection, sample ID generation, and generate test results, and you can publish those results to the patient's profile. And and the next big question we have been asked almost every time we talk about locally homemade this solution is why we go for this homegrown solution. So to make my story short, I just want to share this cartoon. I think you may have seen this many times earlier. Now, for a solution like tire swing, we can't spend money on a roller coaster price, something like that. And since now they have trained all these doctors, qualified in biomedical informatics. That's the biggest resource we have. And we have created a group called BMI group, and we started collaborating with the National Cancer Institute, University of California, and University of Moratuwa. The University of California gave us support for the development, and the Moratuwa for the maintenance, hardware maintenance. And our journey started in 2012 at the National Cancer Institute, Maharagama, and the total system was designed by medical officers in health informatics. And the software development was done in consulting with Dr. Gamini Vichayaratna of University of California. And the system developed by a team from the Department of Industrial Management, University of California. And training of users of usage, how to use this system was done at the Health Information Research Unit at Cancer Hospital, and piloting and first implementation at GH Gampala, and then now we implement this at many places like Cancer Hospital, Peradeniya, Castle Street Hospital, and the District General Hospital Mathale, and TH Kurunagala. And every institution, almost every institution, now Cancer Hospital we have patients about 1,000 patients per day, and at Peradeniya it's close to again to 1,000 patients, and Castle Street about 500 patients, and Mathale and Kurunagala another, I think, third largest hospital in the country. And I just want to show some photographs. This is the design team and all doctors in biomedical informatics. And from the beginning, we had many stakeholder meetings with almost every sector of the hospital services, from the nurses, the other categories of staff, and every training session and every discussion resulted in a more user-friendly system, because we applied this agile system, more flexible agile system, to provide the maximum to the patient without restricting, maximum to the user without restricting the ability to the healthcare worker to use this system. That is very important. And these are my developers. And this is how we implement this at Cancer Hospital Maharagama. And these data entry operators are usually known as the minor staff members. We have given them for the ministry for giving us all this support. And thank you very much for the.
About 10, 15 years back. One of those hospitals was Purnagala Hospital. Now, Dr. Prasad Dhanathanga will be talking about this old system. His topic will be transitioning from a decade-old legal system experience at Provincial General Hospital, Purnagala. Dr. Prasad Dhanathanga is the medical officer, health information at the Provincial General Hospital, Purnagala. He plays a leadership role in managing a team who manages the HIM, a software used for hospital information management and migration to the new system, Health Information Management System, HIMS software. He is also visiting lecturer to the Postgraduate Institute of Medicine. He is currently involved in island-wide implementation of the HIMS software developed jointly by Ministry of Health and University of California. Over to you, Dr. Prasad.
Thank you for those kind introduction, Dr. Saminder. I would like to, my presentation is on a legacy system which has been in use for the last 10 years and is in the transition into a new system. A legacy system, by definition, there are few definitions when I searched about it earlier on, is a software system that is, which is a large software system that won't know how to cope with, but with cope with the new technology, but is vital to the functioning of the organization. There are few other definitions as well, but when we consider all definitions, the key points are that it is usually a large code base with millions of code written in a usually obsolete language, maybe years age, maybe a decade old, and there is lack of consistent documentation. There is poor management of data, usually flat file systems, and it had been so much so much change had been done. The structure had degraded and very difficult, if not impossible, to expand, and usually runs on very old hardware. So such a system is in use at Provincial General Hospital, Kurunegala. The software is called HMS, or Hospital Management Software. This has been launched in 2003, and actually the system had been launched elsewhere earlier. This is the only place which had the test of time and is being still used, and the system uses about 100 computers. There is a old application server, a network spanning the whole hospital, which is connected using about 28 switches are there. I'll just show you some screen captures. This is the login screen, and there is a plethora of menus that cater to different aspects: patient admission, bed allocation, pharmacy, theatre, equipment management, inventory system, pathology.
admitted using the system, only a very few, only a very small proportion is used for ward admission using the system. All the patients are admitted to the hospital using the software, but the ward admissions only a very minute amount is done through the system, and it had drastically reduced since 2010. When we looked at the reasons for this decrease, we found that the software was very slow in response, difficult to navigate. There are so many menus. If it's very difficult for a new user to get used to the system, the options are difficult to be found, and difficult to backup. Backup is, I think, our system administrator is among you who is doing the difficult job of backing up daily. It's a difficult task. He has to run a script, separate script. Slow, and the other thing is the of those listed here, we use database wrapping. We use forward database wrapping, where the old system was can be seen here, and a wrapper is placed here which communicates with the DBM database management system, and a new interface is here. We used Java programming to access the Microsoft SQL database, and the new system is was like this, and actually we used a few modules to be used in ward, where we can easily admit patients to the ward where was the greatest bottleneck was, and of course rudimentary sort of a diagnosis ticket, diagnosis card generator, and a module that could generate statistics for the ward. That is the feedback they get. But still, users are happy with this, but the development was difficult. The database was difficult to handle, and just for an example, if I show you, these are the tables, 192 tables in the old database. This was very difficult for us to manage with. So, what can we do? We just cannot be left out in the dark, and so we thought of Thank you, Dr. Prasad. Now, we'll call upon all the presenters here onto the table, and then we'll open the floor for questions. I think Dr. Kulatilaki is not there, but other three presenters, they can come. Ranasingh. So it's nice to hear you that you have implemented anyway HIS system at Panagura Hospital where I did my internship. So what is the data backup protocol that you are using at the moment? How many servers you are having?
We have a one server,
Running all the applications?
and we have a backup server.
Uh-huh.
So data is stored mainly in a DVD, which is automatically back up every day at a particular time. So every day we have to check whether it has backup or not for the security purpose. So it's running smooth.
Anyway, you are running the whole system using a single server.
Yeah, only one server, but we have a backup server in a case problem creates. So the system won't disrupt.
Then the second question, how many barcode generators do you have at the OPD to cater this 1,500?
Now at a time, there are about 8 medical officers seeing the patient. So each one has each computer, so each one has a separate barcode, roughly about 8 barcode. And printers, actually we don't give printers, there are only 1 or 2 printers. If it is prescribed outside, we can print and give. And we don't have to print because we have interlinked with the pharmacy dispensary. So the system has all the data. So the prescription is going to the dispenser. They have a separate screen, so they can go into the patient's health indication card, and they can see the drugs which has prescribed by the doctor.
Incorporated your radiology and the PAC system?
We have already give that that we have developed the infrastructure. The problem is we don't have a digital X-ray. So if we have a digital X-ray, definitely we will link with the system. But infrastructure is already prepared. We have put the fiber optic lines and everything is ready.
Thank you. Can I ask this question from Dr. Nishan? You talked about like an EBHT at the system that you have implemented at NCM and Ragama. Now, one problem that we find is that in clinical settings, entering of data to on patient care is a time-consuming thing, especially for the house officers and other doctors who are involved in that. How do you overcome that problem?
Now, data you enter to the EPHT is done not only by the medical officers. If you gather information from every corner, every place the patient has encountered. So from the demographics you get from the admission count, and likewise from the labs you can upload these data to the EPHT, and on clinical things, clinical findings of course you can enter, but at the moment we haven't implemented because of the hardware issue we had, because we had to purchase few equipment, but we have managed to run this at consulted hospital where they enter certain clinical data and print the diagnosis summary as well.
So the daily entry of data in clinical management is not it.
Yeah, it's a hybrid system because the thing is now talking about totally paperless system running in our government hospital is quite impossible. We'll have to face the reality. So of course will maintain these hard copies, but at the same time certain information we can store electronically, and we can use those both information to summarize this patient's treatment summary.
Thank you.
Yeah.
Another question. So, Dompe and Panatura, they have implemented one system. So, the system that you have developed is a separate system or a derivative from the system that they have using?
Well, I think the system developed for this Dompe and Panatura was mainly focused on OPD management. And then I think there was a time they shifted from OPD to certain inward sections. But from our end, we started this for the inward patients, for patient registration, and to maintain the clinic details for the patient, and that sort of activities, as well as the other, to integrate all the other information like RIS and lab systems. So it's not a, I mean, we are totally different, running totally different systems with a totally different origin, because this, the system at Cancer Hospital was developed by our own staff and developed with the guidance from the health staff, and it's totally managed by doctors and the other staff from the hospital. Whereas I think Dr. Ansigma.
Actually, that software has other modules also, the clinic management system and the inpatient management system. But we haven't gone that far because this is Sri Lankan setup. So we have to slowly train our people in the OPD and slowly shift to the next step. Now we are trying to shift to the clinic setup, and we are trying to experiment it in the PCU level, primary care unit, as a remote area. So we are, I think our next step is, second stage is going towards the wards.
What is the backend that you are using?
Sorry?
SQL backend database?
That detail, I think Dr. Paul is he's here, so those technical details I'm not aware. But it's an open source software which is given by ICTA, HHIMS.
Then these systems, are they comply with this meaningful use or HIPAA compliance?
Sorry, I can't hear.
These systems, I mean, there are two HIS. So are they comply with meaningful use to MU or to and HIPAA compliance?
I think I can talk about it. There is a forum between the ICTA and the Ministry of Health to streamline the health information management systems, and we have regular meetings. We are trying to identify data elements which should be captured from hospital information management systems, and that needs to be transferred between hospital management information systems, and then find out the most probably the HL7 messaging. We are going to use the HL7 messaging. So the required message, and then we can ask both developers to incorporate those into the system so that there will be interoperability. We do not want actually one system to be implemented island-wide, because then it's a monopoly, and there is no incentive for a system to be improved. At current context, I think what is being done is just getting rid of paper. The same thing, you can make the same mistake that you do manually in the electronic health system, but we want to improve it. If we capture the weight, then we should be able to have the correct drug dose calculated. If you prescribe 2 drugs, you'd want to know what are the interactions. And if you have allergic history recorded in a previous visit, we want, rather than just showing it, we want people to highlight that even if it's another drug from the same group, we want to say, okay, it's a quinolone, don't give it. Things like that. We want to improve, and also at the prescription, at the time of prescription, that is the best time to educate the doctors as a continuous medical education. We could give the drug protocol, say if it is community-acquired pneumonia, go by this. That will make a marked improvement in the healthcare delivery. So I think the forum is already set, and we will work forward. Thank you.
Do you have any plan for partnership with private sector to exchange the challenges and ideas with private hospitals and your hospitals?
I think there is a maturity level that we have to achieve. We can't have the full integration at step one. Now we don't know, actually we have not done a proper study as to find out what is the information that is required by the, say, the vertical programs, say the MCH. From HIS, what do you need? So we are, as first step, we are going to find out what is required. And then we will open it up for the ministry. We'll pilot it there because we are going to follow a standard, HSM or something. Then we will be able to ask the private sector. They don't have to come to us and get them. We just have to say, this is what we are doing, this is a standard, go by it. Then once we authenticate that system, they'll be able to transfer data and receive data from our side as well.
My question is implementation point of view, project management point of view, to share the challenges what the government sector is facing and the private sector also facing a kind of challenges to implement HMS and this kind of systems. So is there any kind of plan to collaborate with both these parties?
In the ministry, I am not sure. Maybe forums like this, and also the Health Informatics Society of Sri Lanka, where many of the health informatics professionals, it's open for the private sector as well. There are, I think, organizational members like Kasari Hospital. So they could come to that forum and discuss your issues. Probably we can go about it, the Postgraduate Institute of Medicine, the IT universities, both can collaborate and do that sort of research. I think in the interest of time, we'll stop the questions, and we have, the next would be the tea, and thereafter at 4 p.m. there is the plenary symposium number 3 on ethics, law and information security in healthcare IT. So please be present for that. The tea is served outside. Thank you.
Just a minute, Chairperson. I would like you to hand over the awards, the certificates, to our speakers today. To Dr. Sampath Ranasinghe, Dr. Nishant Sirivardhana, and Dr. Prasad Ranatunga. Ladies and gentlemen, thank you for attentive participation. Let's break for a quick tea.
At the outset, I must thank Professor Vajra Disanayaka and the Health Informatics Society of Sri Lanka for providing me this opportunity to present in this distinguished conference. First, I will brief you on the key ethical concepts, and then I will take you through some of the new trends in healthcare IT, and then we'll discuss about ethical implications of these trends, and finally we'll discuss about strategies to deal with these implications. Ethics is defined as moral principles that govern a person's behavior or the conducting of an activity. This is the definition given in the Oxford Dictionary. So there are basic fundamental ethical principles which all social interactions are subject to. Most important of these principles are autonomy, which means all right to self-determination of a person. Then all persons are equal as persons and have equal rights. All have a duty to advance the good of others and also to prevent harm to others. All rights and duties are subject to possibility of meet them in a given circumstance. That is called impossibility. And one's duty to fulfill the obligation to the best of one's ability is the integrity. International Medical Informatics Association has published a code of ethics for health informatics professionals. And in this code, they have also identified some fundamental principles of ethics. First one is information privacy and disposition, and openness. Then security of information, then access of information, legitimate infringement. Legitimate infringement is the authority, whoever collects the information can do things with this information, can process or do secondary analysis only if there's a legitimate need to do that, and or if it provides betterment to the society or to other people. Then there's a principle called least intrusive alternative. That is when a person's fundamental right to privacy and ethics is breached by a authority, it has the authority is doing that has to do it in a most least manner, in a manner which violates his rights in the least. Then there's a principle called accountability. That is, if one person's private information is used to other things, the authority who's doing this that has a duty to explain to the person whose data is used as to why and how the data will be used. So I'm going to discuss about some of the new trends in healthcare IT. One major trend is technology trend. Technology has long been a valued resource in healthcare, but now more than ever it has become a must-have tool for transforming patient engagement, enabling personalized medicine, or augmenting labor, and contributing to better outcomes. Then there are policy initiatives and new laws. According to WHO, most countries have taken steps to establish legal frameworks for the protection of patient data. Then with one of the other new trend is improved access to healthcare. Now people can access to healthcare and health information more than what they could about one decade back. Some health information you can find in the social websites also. Social media, then private websites, private blogs, everywhere health information is there. That is one trend.
Then adoption of standards. WHO says that their member countries are progressing in adopting interoperability, e-health architecture, data, vocabulary and messaging standards. Let me talk little more about technology trends in healthcare IT. There's proliferation of new technology in healthcare, and hardware is becoming more and more intelligent. If you have seen the stalls in our conference, you may have noticed how intelligent now the software and the hardware devices are. There are smartphones with various medical apps. Then there are wearables which ought to improve patients outcomes, and it will help immensely the doctors and caregivers. And then there's personalized healthcare. In near future, patient will be in the center of care, and with the implementation of EHRs, lot of relevant data of a patient will be there with the reach of the patient itself. And with personalized healthcare, there's personalized medicine, which talks about genomics and proteomics and things like that. Then there's platform evolution. Mobile technology and web technology with cloud computing has revolutionized the platform, and there's ubiquity in healthcare IT nowadays. Then there's a concept called big data, which is very much talked these days. And big data is expected to uncover patterns, problems and opportunities in healthcare, and this will help not only the clinicians and the healthcare administrators but also the researchers with immense amount of data. With all this, there's increased threats to e-health systems. According to a study published in March 2014, they have discovered that cyber criminal attacks to healthcare organizations in US has doubled in past 3 years. So let's discuss about the positive ethical implications of these technologies. Everything has positive and negative. So one positive aspect is improved patient safety. Technologies like EHR, wearables, medical apps would improve patient safety by providing accurate information on time, reducing prescription errors, preventing adverse drug reactions, assisting in correct diagnosis, and so on and so forth. Then there's expected improved organizational efficiency. This is also due to technologies. These technologies would improve efficiency due to the inherent features of electronic data. Then secondary use of data for medical research. With big data and cloud computing, researchers are they can get a huge amount of data to do their researches on. And these researchers are expected to lead into new innovations. Then there's minimize innovation and minimize invasive investigations and procedures due to these wearables and intelligent hardware. With the personalized health, individuals take ownership of their health. So much more, this all will. However, there are negative ethical implications also in these technologies. There are number of security breaches in e-health systems which violates patients' privacy, and some of the technology malfunctions or defective technology will lead to threats to patient safety. If the EHRs and other health information systems are not properly designed,
implemented and monitored, they will actually lead to organizational inefficiency than efficiency. And there's equity and equality issues in healthcare arising with things like personalized medicine, and big data with immense opportunities also is a threat to privacy, confidentiality, and identity. There are identified ethical implications in cloud technology. There are issues in control or ownership of data in the cloud. Then there are also issues of self-determination, accountability, function creep. That means the data in the cloud will sometimes be used to things which are not intended in the at the collection. Then if only few companies give this cloud services, there's a threat of monopoly and locked-in, and there's always privacy issues. Let me talk to you about briefly about ethical implications of other e-health trends like policy initiatives. Policy initiatives on e-health are very good, but then the people who are implementing or designing these policies have to see into all ethical aspects are included. And similarly, when they are legislating, when they are drafting new laws, all ethical implications must be considered. Otherwise, this new laws will lead to other ethical dilemmas. Then, with the improved access to healthcare through IT, there will be instances where people will be misled and wrong information given through private websites or social media. Then adoption of standards, if done properly, will lead to confidentiality, integrity, and availability of health information. But not adopting these standards would compromise these aspects. So let me give you some strategies to overcome these negative ethical implications. One is evidence-based e-health policies and related laws. Then adoption of standards of e-health, which Sri Lanka has done tremendously well, I must say. Then I propose a code of ethics for health informaticians and ICT professionals who involve in development and implementing e-health systems. Then there should be an ethics review committee specialized in health informatics. As Professor Vajra Disanayak said, we already have such ethics committee at HISL. Health Informatics Society of Sri Lanka has established an ethics review committee with the primary objective of promoting the rights, dignity, safety, and well-being of persons of whom the information is entered, stored, processed, transmitted, or archived in health-related information systems. So in conclusion, healthcare IT has ethical implications. And awareness among professionals, including health administrators, clinicians, researchers, as well as politicians, is important to overcome these ethical issues. And there should be codes of ethics for medical professionals. There should be codes of ethics for health informatic professionals also. And there should be specialized ethic review committees which specifically look into ethical issues related to health information systems. Thank you.
experiences in several countries with internationally known legal expertise in electronic commerce, information security, cybercrime, intellectual property rights, software licensing, privacy, payment systems, e-banking, internet governance, and I think it's a broad spectrum that he is having his expertise. So over to you.
Thank you for that introduction. How much of time do I have? Okay, thank you. So I can eat into my colleague's time. Thank you very much for inviting me to do this presentation. And I'm privileged to be part of this very eminent group of learned professionals in the field of medicine, especially my old friend Professor Vajira Disanayaka, whom I have known from childhood days. So being part of this group is being like part of the family. I just reminded myself of some very energized interventions last time when I did this similar presentation to the eHealth gathering last year. And one of the take home was that we would have a follow-up activity plan to take on issues raised during the workshop. And there was a lot of enthusiasm immediately after the session, but gradually over the months that enthusiasm died down, and I'm pleased to be here again to resuscitate that enthusiasm, whatever that is left behind, and hope this time we can have a couple of follow-up activities to energize us as policymakers to reform and continue the process to meet the next generation requirement, even in the legal sector. So, by way of introduction, the scope of what I intend covering is as follows. As usual, I have to cover my bread and butter stuff to give everybody an overview of where the ICT sector as a whole stands in Sri Lanka in comparison with other countries, and where we are measured in terms of progress in terms of the network readiness index. And then I will come into the pith and substance of some of the essential reforms, both pending and already available, specifically to address matters arising from the entire e-health ecosystem, or to support that ecosystem. And with that, I will have some conclusions to which I hope you will also add some value. So in terms of our ICT sector in Sri Lanka, compared to the time we started on the subject 17, 18 years ago, Sri Lanka has improved rapidly in the ICT sector, making this sector the 5th largest revenue earner for the country in terms of net export revenue. In the early days, we were in the range of about 30-40 million US dollars. Now we have gradually gone up the scale, and from the IT BPO sector, software outsourcing sector, and I know there are companies doing medical related outsourcing work in Sri Lanka. All of this together is adding a lot of value. As a result, we now have a situation where we are nearing $950 million to $1 billion net revenue, and of course there are various kinds of statistics, some of which I don't really know how accurate they are, because there is not enough reporting by companies about their revenues that they generate, realizing that one day they may have to pay taxes on them. So disclosure is a problem, but nevertheless the estimation is that this sector is at the 5th revenue earner for the country. Now this did not happen overnight. It happened due to a lot of efforts by numerous policy interventions, starting from a law we don't talk about, we take it for granted. That law is the Telecommunications Act number 25 of 1991, which was the first law in South Asia of its kind to introduce liberalization and competition in the telecommunications space. So that's why we have so many mobile providers, multiple internet gateways, so that there will never be any internet censorship possible, because if you close one gateway, there are multiple gateways on the external internet traffic operations to take place in the country. So many ISPs, we have more mobile phones than toothbrushes, as we say in South Asia, right? You have one toothbrush, but I know many of you have got 2-3 devices that have got SIM cards. So you have several mobile devices. This sector, the IT BPO sector, is growing at about 30% per annum. Again, no strict criteria to measure the growth. And for a couple of years running, Sri Lanka is #1 in South Asia in what is called the Networked Readiness Index, that measures ICT performance in a country. You can download this report. It's an independent report that spreads out the performance of countries which are the rest of the other countries. And there are so many sub-indices, and I'm happy to say the fact that Sri Lanka's e-health or ICT adoption in the health sector has also been captured as one of the sub-criteria in the measurement of one index that has helped Sri Lanka move up in the ranking so effectively over the last several years. So that's all about the overall policy landscape. In terms of e-health and legal issues, I realized last time that some of the doctors are better than lawyers, because they ask very scientific questions, you see. So I thought I'll make it very simple this time without going to too much detail of the law, and I narrowed down the broad spectrum of issues to the following. The question often is raised in the context of e-health and all the digitization work that you carry out in the health sector, whether there is legal validity for electronic documents or electronic records, or whatever you call it, whether you are able to get legal recognition for electronic storage of health records in digitized form and produce that as the original in court without relying on a paper document. And then comes the question of evidence admissibility in court in the event of you having to present that record, electronic record, in a court of law. So I thought I'll address those three first, and then come into the subject of prevention of abuse, with all this technology being adopted in the health sector. This sector is also will be subject to abusers, where your critical information infrastructure will be subject to hacking and botnet attacks or denial of service attacks, and people may want to take information from hospital databases for themselves. I mean, that can easily happen. It has happened in a number of countries. So what are the preventive measures that are needed? What have we in the country as policymakers done in recent times that has helped to uplift Sri Lanka's image and create a better ecosystem in this subject area? So I will address the whole aspect of cybercrime, information security and the law issues, and with some focus on a recent development taking place just about a month and a half ago. And then of course finally on data privacy and protection, subject very dear to the heart of all of you as much as it is to mine, right? Now in terms of our electronic transactions legislation, and I thought that is the core piece of law which will specifically address the three issues I mentioned earlier, right? Legal validity of electronic documents, whether you can retain them in electronic form and use that electronic form as the original record in a court of law. So those three areas are broadly covered under the Electronic Transactions Act. The prevention of abuse dealing with criminal justice aspects of cybercrime, we have a separate law called the Computer Crimes Act from number 24 of 2007. So those are the key pieces of legislation that I will be dealing with. If you look at the Electronic Transactions Act, I have cut and pasted what we call the head note of the statute that allows not only a judge or a lawyer, but even a layperson to understand what the law broadly covers. So I have highlighted in bold caps the key phrases that are relevant for our consideration today. So this is an act not to regulate, it is an act to facilitate and recognize a whole series of activities. What are the activities? The formation of contracts, the creation and exchange, Ganudenu as we call in Sinhala. Exchange of data messages, electronic documents, electronic records and other communications in electronic form in Sri Lanka. I think I will stop at that semicolon because the words and the phrases after the
compared to other industries, the health industry has significantly underutilized technology to improve operational efficiency. This is for argument's sake. And this is the outline of my presentation. I'll be talking about Sri Lanka CERT, the threat landscape, and some awareness issues that are very important. Sri Lanka CERT, or Computer Emergency Readiness Team, was established in year 2006 under the ICT Agency of Sri Lanka. We are full members of FIRST, Forum of Incident Response Security Teams, and AP CERT, the Asia Pacific CERT, which is a collection of Asia Pacific based CERTs in the region. As you can see in this slide, the threat agent, the malicious user, is targeting the weakness of the asset. As an example, a web Apache server. The unpatched version of this software is the weakness. Exploit is making use of that weakness. This gives rise to a threat. These are some of the various sources of threats. You can have disgruntled employees, activists, and foreign states and organized crime groups as threat sources. Introduction of new technologies change the vectors of attacks, resulting in change of threat landscape. Velocity, variety, and volume increase in the era of big data. The emergence of shared medical records makes errors all the more dangerous because they can propagate more easily between providers. $70 million people in the US are using wearable tracking devices to monitor their physical activity, sleep patterns, calorie consumption, and various other things. Many healthcare providers haven't yet tapped social media to build relationships with customers. In this slide, you can see various avenues where big data is generated. Social media, mobile devices, scientific instruments, and sensor technologies and networks generate this big data. In Australia, a hospital sent the wrong discharge files to physicians in 2011, mixing up patients' diagnosis and test results. In the Internet of Me, we can see more investments in personalized technologies. Patient data is residing in many places and can be accessed quickly. These data are extremely sensitive. Confidentiality and integrity are key security features of these data. Regulations like Health Insurance Portability and Accountability Act in the US and Data Protection Act in the UK are very critical. These are the threats you can identify in the threat landscape. In drive-by exploits, just visiting the sites is enough to get you infected. Configure is a worm targeting Microsoft Windows operating systems. In this slide, you can see various avenues how this configure worm can get replicated in various other systems. Attackers try to extract data, steal credentials, and take control of the target web servers. This shows a step-by-step incident where a cross-site scripting takes place. First, the hacker infects the web page with the script. Then when a victim visits this website, the script is injected, and in turn it will do something bad. So this is a simple example for a cross-site scripting attack. Malware as a service is an emerging market. Ease of use and support after sale increases the demand for these exploit kits. Even though how careful you are, sometimes a data breach can happen. Now in that case of a data breach, these are the repercussions of a data breach. You have to notify the stakeholders, and there can be identity theft instances, and legal help is required. Also, in addition to that, regulatory fines, and most importantly, impact on customer trust. Now there is a sentence in bold in this slide. Reputation is one asset, not fully restorable. So it's an important message. Now I'm going to ask you a simple question. How many of you use power on passwords for your devices? Can I have a show of hands, please? I mean, that is a very simple mechanism that you can implement to escape. I mean, you can. I know that many BIOS passwords can be reset by just removing the BIOS battery and then erase whatever the admin passwords there, and you can proceed. But it's an additional layer of protection you can have to your device. And how many of you have encrypted hard drives like BitLocker? That's also an important step when you want to ensure sensitive information are not compromised from your system. When you talk about encryption, you have to always remember you need to cryptography is an example for a technical control, and biometric sensors, placing a security guard at the premises is so it lowers costs and risks, identify malicious users, and fewer help desk calls. These are some of the examples for lowering costs. And we have some standards implemented in strengthening information security. For example, COBIT, ITIL, ISO 27/2002 Code of Practice, and EU Data Privacy Directives and Health Insurance Portability and Accountability Act are some of them to mention. So if there are any incidents that you want to report, you can actually send any incident related information, or if you encounter a security incident, to CERT, our website, cert@cert.gov.lk. Plus you can reach us through the given mobile numbers and given landline numbers, and through our website you can read furthermore about Sri Lanka CERT. Thank you for your patient hearing.
You have to and also confirm that it has not been tampered with. Now the thing is, most of the systems implemented currently, I'm not sure whether they have that audit trails and requirements to safeguard it. Now, what is the responsibility of the implementers, the programmers, and then the hospital administration with regard to implementing a system which cannot give that data to a court saying that it has not been tampered with? You don't have that evidence. What is the the responsibility of the hospital or the developers?
Thank you for that question. Am I heard? Yeah. So, as follows. Uh, there are two standards, availability of that information for subsequent reference and showing integrity. Integrity or non-tampering can be ensured by having information security and other policies within that organization consistent with acceptable standards. There are ISO standards and so many other benchmarks you can use. As long as you use a benchmark that is commonly acceptable by industry, never mind about the solution, if that standard or the framework or the policy adopted internally is acceptable and acceptability in a court of law can be proven by demonstrating that that particular standard is in use in comparable environments, either locally or internationally. And if that is ensured, then you can get protection under Section 5 and 6 of the Electronic Transactions Act. And when it comes to admissibility in court, the business records exception framework that we have created under the Electronic Transactions Act is available because you have conducted your activity within the framework of an accepted, regularly conducted business following a norm that is used in comparable situations in another country or in a local situation. So the short answer is, it's important to have information security policy. It's important to get that policy and audit it and ensure compliance not on a just 5-6 year basis, but on a yearly basis to ensure that you have a framework that is acceptable, consistent with international standard or a locally adopted standard. So ISO or comparable BSI standard is the way to go. So that point is well taken, but I'll answer your first point. What I meant was, it's not the cyber law that we have adopted, but cyber law is a stack of laws. So intellectual property, payment devices, protection, payments and settlement systems, electronic transactions, cybercrime. We have all of it. But what we don't have is a dedicated law to deal with privacy and data protection. Your point is well taken. It addresses exactly that. The role of the data collector, what the data collector has to do when it collects data from a data owner, how the data collector can process it, how and when a data collector can share it with third parties. Those are the issues that are generally dealt with under data protection law. But the lack of a framework, I know amongst many of us, it creates a lack of confidence in dealing with a website or web-based e-commerce platform. But the answer to that is often found in the individual company privacy policy. So if you go down on a web portal and you are dealing with a local, forget about a local, very often you buy products or services from a foreign web-based framework. So when you do that, if you have to check and see how and in what circumstances the information that you provide that site including your credit card information, how and where it will be collected, or does it collect the data, or do they have a deletion policy? So those are issues that are often dealt by companies in a privacy policy. But nevertheless, to ensure standardized approach, many countries adopt a data protection kind of legislation. It's a big step. It creates an administrative burden on financial institutions, to government, to all sectors to ensure compliance. But I think now that we have reached a level of maturity in digitization and with the government prioritization in that field, the time is right to deal with the subject. Thank you very much.
Thank you very much, Jayant. I think with that, we'll bring this session to a close and we'll move on immediately to the next session. I think before that, my co-chair will hand over a few tokens to the speakers.
Ladies and gentlemen, we have come to the last event of the day. That's a plenary roundtable to discuss the future of digital health in Sri Lanka. I'd like to invite Professor Vajra Disanayaka and Mr. Vinod Haturumani to come to the come and take over the session.
Faisal Samat is unable to be with us today because he's indisposed. So in his place we have
Jagadish Ravani, not Vinod. So Jagadish is the coordinator of the business club as well as as also some of the special editions of the Sunday Times Business, as it were. So the plan for this session is for us to air some views, share some ideas with the audience. I'm going to call on stage a few people, but I would like the others also to participate, and I think those of you who are on the far end of the hall, if you come onto this side, it'll be easy. There's a light which is kind of flashing on me, so I don't see that side. So to begin with, then may I invite a few people to come on stage. I will begin with Mr. Muhundan Kanagi, who is the Chief Executive Officer of the ICTA. I will also invite Sri Ananda Ratnayaka from the ICTA. Then I would like to invite Pradeep De Silva from the Ministry of Health. I think we also have Clive James. Clive, Clive has gone for a meeting with the minister, I think. We have Pradeep. We would also like to invite Alvin Marcelo to come on stage, as well as Sandeep Sahe to be here. And I saw Mark as well in the audience. Is Mark yeah, or did Mark Mark land? Is the Mark is not there, is it? Okay, and I would also like to invite Apsara Vijayratna from the from Digital Health, Vijayawardena from Digital Health. So we have a cross section of people. Then we have the ministry, we have international organizations, we have ICTA here, and so that's the panel. I think this is Mark's share. I wonder whether we can find Mark and bring him. Well, if some of our organizers can give a shout to Mark if he's around. I saw him here. Okay. So let me begin then by maybe making a few remarks, and then we'll send the mic around for everyone to say a few things, and then we will also let the audience express their views about the future of digital health in Sri Lanka. And we also have someone here, rapporteur Chaminda Veerabhadana, who is taking some notes. And we would try to see whether this can be formulated into some form of recommendation with which the Health Informatics Society and the ICTA and other stakeholders engage the political establishment in the country and to say this is what we would like to see happen. And so that is the intention of this roundtable, as it were. So to begin with, to make a few remarks, I think personally I see several things happening. Number one is already alluded to in my talks in the morning. We are going through the demographic transition. So we are going to have aging population. At one point in time in the medical field, we used to say that we have the fastest aging population in Asia behind Japan. And as you know, we are aging at a much as a proportion of the population, right? But we are aging with a very much lower GDP in our country, and we have all these people who are old, who are not working, and we have to look after them with less resources. Whereas Japan is a different story. That's number one. Number two is the pattern of disease is changing. Today in the morning, you heard the Director General of Health Services say, we have eliminated this, we have eliminated that, and so on. So I would say those diseases we have eliminated were easier to tackle because you had acute episodes, you will treat, and then you are cured. But today, we have non-communicable diseases which are incurable. So you are going to live your entire life with it. And therefore, we have to manage them. And for, I guess my estimation is as good as yours. Today in the morning, again, one of the presenters said we have 73,000 hospital beds, but 25% of our population has diabetes. So if all those hospital beds are, occupied by, diabetes patients, which is not the case, let's say, let's say 25% of those, 25,000 of those beds are occupied by diabetes patients, then there are 1,000 patients in the community for every patient in the hospital. So again, we have to manage them in the community. So that's another paradigm shift that we are seeing. The third shift, of course, is the shift that medicine is undergoing in terms of how we deliver healthcare. Because of great advances in genomics, we are now moving on to personalized healthcare based on a genomic profile of a person. And how do we deal with that? That is also becoming an issue. How are we going to integrate that? I think these three, to me, are basically key challenges that we will face in the future. And I personally feel that there are solutions for them within digital health, and we can think about those. So those are the thoughts that I wanted to share with you as preliminary thoughts. May I pass on to Munda to express his views?
Hi, good evening. I guess we're just, having tea and lunch tea, and I'm sure we're just ending up with some biscuits up here. But the whole fathom that I'm trying to actually bring in is about, the whole day you would have spoken about so many different varieties in healthcare and aspects of it. But I think what we need to come up is truly where does the problem lie in areas of digital health, and what is the adoption towards digital health. We spoke about patients' records, you speak about many other areas of connectivity and things that we would bring in terms of digital infrastructure. But fundamentally, is creativity coming from health? Is there innovation coming from this sector at the pace at which the rest of the world is moving? I think these are some of the key questions that needs to be answered. Is the medical profession by itself opening the doors to newer breed of innovative ideas coming into its sector? And because as we talk about continuous healthcare, instant healthcare, healthcare to the home, and all these types of things in these areas, but there needs to be innovation and things that need to foster within the ecosystem. And that's something that I mean, sometimes I ask from an outside perspective what is happening in terms of that area within healthcare itself, and within the medical profession. And is it because it's too regulated? Is it because it's, I mean, there's lots of outcry saying it's over-regulated. Now, what's being discussed about that? Now, technology devices are being produced. You go to the Silicon Valley, you see many technology devices, you see Fitbits. You have so many technology companies coming up with different things, and you have lots of data coming out and all that. Well, where are the data scientists behind these analytics? that would produce greater insights to medical professions. So I think there is, while we actually bring in digital healthcare, I think that whole ecosystem needs to be built, and that really needs to be looked at as well. And that's something that I would just want to address so that we could have some conversation on that particular topic as well.
Good evening. As Professor Vajra correctly said, that we have the double burden of the non-communicable disease. Again, especially in the health sector, we know that non-communicable disease, you require adapting systematic adaptation of the healthcare to manage the disease. So when it is come into the management disease, you require the fundamental important aspect of the health information. So we know that the health expenditure, today health expenditure, when you take it, 47% is government and the 53% of the private sector health expenditure. When it is coming to again to the private health sector, more than 80% is coming from the out-of-pocket expenditure. So, seeing and looking at the importance of the efficiency and the quality of the healthcare in the private sector, we see the tendency of the moving the patient to government to private. At the same time, the cost is a major threat, and because of the cost of the private healthcare sector is high, not like the government sector. The patient access the healthcare in piecemeal basis or the ad hoc basis. So because of that, non-communicable disease are not managed properly sometimes. At the same time, as you correctly said, though we have properly eliminate some of diseases, but new diseases are emerging. We saw the impact of the Ebola. So whether we have the correct screening process to get to sweep out the new challenging communicable disease. I think there is a major role in terms of the health records in the health sector. So the fundamental requirement is, I think we require to have the basic foundation of having health record across the government and the private sector. Then on top of that, we will be building the so much of lucrative application and apps and so on and so forth to give the facilities for the patient and the citizen. So
okay. I'm from Digital Health. That is basically a subsidiary of Dialogue, and this is a new vertical in Dialogue that we have introduced. And we are in the past we have done CSR projects which was focused on health, but this time we have a separate vertical and we are quite serious about this. And coming from our main Dialogue vision, basically we are here to bridge the inequalities that we see in any other arena, and health is one of the arena we see there's a lot of gaps. So what we are doing right now is we are waiting and sitting and listening to most of the problems that we heard here, as well as the gaps that we see. So we are waiting to work with you all, different organizations, different standards, policies, different bodies. And one of the main concerns that I was hearing was the EHR. Yes, and I think public versus I don't want to get my private hospital colleagues upset over this, but I feel the public side has done a lot of work, and private medical HCPs, basically hospital healthcare partners, can follow. And coming from the EHR side, from the EHR side, from the hospital side, I feel the public hospitals are doing a lot of infrastructure. They are putting a lot of money behind infrastructure and getting that part ready to mainly to put the foundation for the EHR. But I think from our side, as telecommunication, I'm not talking here as a telecommunication partner, but the thing is from the digital side, what we have here is we have a lot of infrastructure that we have set down all over the country, and we have a huge subscriber base. And we have, if you look at the literacy of this country and the people who are holding mobile phones at any given time, we have 107% of mobile phone penetration. So that means if we can use that as a lifestyle to bring the patients, the customers to handle their own health in a better manner, and which more convenience, more care. And while the public sector is having the infrastructure there, if we can bring the patients to them, to the private hospitals, who are, if you all are ready, we can bring the right patients with the right enability to you guys. Okay, thank you.
Thank you. Before I send the mic that way, just want to add a fourth item to what I said before, which eluded me. That was 10 years down the line, don't think the government health service is going to be the dominant healthcare provider in Sri Lanka. That is changing. That's definitely changing, and the private health sector believes that they will be the dominant healthcare provider. Already outpatient, it's the private sector. Inpatient, maybe 25 to 30%, but the private sector has plans to take it up to 70, 80%. So therefore, the dominant healthcare provider in the country another 5 to 10 years down the line will probably be the private sector. And the economists in this audience may correct me. I have heard some economists say that when you reach the $4,000 threshold, per capita income threshold, people like to pay for it, pay for their services rather than, depend on the social care model, and we are on that threshold. So that's another dimension that I'd like to bring it in. So.
From the standpoint of the state health sector, I would like to say that Professor Vajay is correct, because it's actually the tables are being turned now, where the demand for private paid healthcare is more. But when we think of the government sector, it's more or less providing the services to the public at large at a lower cost. So I think the health IT or the digital innovations should actually aim at utilizing the resources, limited resources, in a more efficient manner at first. Of course, the government is receptive to innovation in a way that it would be receptive, so that there may be people who like to invest, and people who would like to experiment would be given a chance. But on a flat-out basis, like implementing something island-wide, implementing in hospitals, the basic information systems which would generate information in relation to implementation, in relation to monitoring and evaluation of certain healthcare interventions. It would be best to have basic information systems, so that these information systems would generate planning and monitoring information. So the government is at present working in the line of developing basic information systems, and of course are receptive to maybe the digital outputs of various investigative machine equipment that we use in the government sector. So down the line, maybe if we are talking about a span of 5 to 10 years, the tables would be turned where people would be able to afford care, and people would try to pay and get the care. The innovations which will make them come to those institutions would be maybe first tried out in government hospitals and tested, and then that would be a better way of dealing with the innovation.
Thank you, Dr. Pradeep. So just following through what Professor Vajir mentioned about the changing landscape of the health sector. I remember in way back in 2000, I didn't have a DSL connection at home, so I would have to dial up to the internet service provider. Do you remember that sound? Right, the sound of the modem. If it makes that sound, you know that you're going to get a connection, but it's very slow connection. Technology is changing very fast. Healthcare is changing very fast. And when you try to mix up two rapidly changing domains, the complexity just doubles up. And I think the challenge now for the Ministry of Health in my country and the Ministry of ICT in my country is how they will partner together, not to create the solutions themselves, but to create that conducive environment to let 1,000 flowers bloom. Because there's this challenge of having standardized systems, which, I mean, if you have one system, then it's basically a standard, but then you don't have innovation. And on the other end of the spectrum is innovation, in which case you might get, following the law of entropy, chaos, and non-interoperability. So from the spectrum of having one standard to environment of innovation, where do you draw the line and who makes that decision as to where to draw that line? In the Philippines, we agreed that there must be a clear governance body to make the final say. So everyone is correct, but there will only be one method, and that will be the selection of our, we call them the National eHealth Steering Committee. It is chaired by the Minister of Health because it's about the health system, but it is co-chaired by the Ministry of ICT, supported by our National Health Insurance Agency, the National Health Sciences University, and the Ministry on Higher Education. So the five of them, they meet quarterly and they make final decisions about investments. And so far in the past 6 meetings, this has worked very well for us because, you know, everyone at the middle management level will have their own brilliant ideas, and all of them are probably correct, but at some point, the investments need to be definite and strategic, and that's the role of the National Health Steering Committee. So in the end, we decided that we should just create an interoperability platform called the Philippine Health Information Exchange. The accountability of the exchange is with the National eHealth Steering Committee. And once the exchange is there, then that is the platform by which all of the innovations will be allowed to interplay and interoperate with each other. And we hope that that will really spur a lot of interactions between clinics and laboratories, between blood banks, drugstores, and hospitals. But without that platform, that platform cannot exist unless there is a governance structure making sure that that is going to happen. And so that's basically, I think that was the message, my message this morning, that there should be a strategy, a governance behind the strategy, and an architecture behind that governance, supporting that governance. So in the Philippines, that's our plan. We're not going to develop applications anymore because you cannot have one application that can do everything anyway. So we'd rather just put up the backbone. I think they call it a spine in the UK. They call it the Malaysian Health Information Exchange in Malaysia. And we're calling it the Philippine Health Information Exchange in the Philippines. I think that's going to be the trend in the next 5 years. Thank you.
Thanks, Delvin. I have a couple of points, sir. I think there's been a lot of discussion on patient-based, individual-based records, electronic health records, etc. And I feel a little uncomfortable. Are we losing sight of the population? No, and I think while going this route of personal-based records, etc., I think one should just look at the experience of the West, where huge amounts of money have been spent in the US under Obamacare, the UK NHS, and they have been quite sort of disastrous, I think, in terms of the investments which have gone in with, and large billion-dollar projects being scrapped, etc. In our context, those resources, I mean, it's not possible like what they're doing in the US for government to be giving incentives to small players to adopt DMR systems, etc. Those incentive structures are not there, resources are not there. So I think we have to be a little cautious on our focus on this personal-based systems and not to lose sight of the population. I think the population should be the frame of reference. That's one. I think another point, I feel big data is an area where the potential for a lot of innovation. But again, big data has to be channeled, and I think the work which I did with WHO, the conclusion was that it could be useful for monitoring of morbidity and mortality statistics, but unclear on how that could actually be done. So I feel there's a potential of creating national and regional sort of data science centers which could focus on big data in our context, what is appropriate, how could it be leveraged, how could it be analyzed, interpreted, and used, I think specifically towards monitoring of mortality, morbidity, because I think that's where a huge potential of this data is. I mean, I've been working with Dr. Vajira here for the last 10 years or 7-8 years, and I think an interesting trend which I've always found, I think, is you have doctors who are very good, very qualified, but somehow I feel they tend to want to become informatics people, and in that maybe they are losing some of the core strengths which they have, which could be around business requirements, analysis, interpretation, use of data, and I think because otherwise you have a lot of resources, etc., getting lost, a lot of efforts getting lost because we don't have a overall kind of vision of. I mean, Sri Lanka, we don't have a HMIS. You know, we typically all countries have a national sort of reporting system for the primary health care. We don't have that. And that I feel should form the cornerstone or the spine of a reporting system for a national health information system.
I would ask my co-chair to now, he's going to grill the panelists.
As Apsara mentioned, the public sector in Sri Lanka is far ahead of the private sector in the sense that all of these basic systems that Pradeep and everybody have been talking about is deployed in the public health sector, but not necessarily with the private hospitals. How did the Philippines get the private sector involved? Because I'm assuming, I probably am wrong, but I'm assuming that it started similarly over there with the public health sector leading the charge.
The Philippine health system is different from the Sri Lankan system. I think we are what you're saying. So our health system is 50% private and 50% public. So I think that's what you're saying, Professor Vajira, you're going towards that direction. So in that sense, we have a number of information systems in the health sector that are in the private hospitals, and because there's no standard yet or platform coming out from the government, then it is safe to say that they are not interoperable. But it's also not their fault because they were not told what standard should be used. And this National eHealth Steering Committee now serves that function of making sure that the different siloed information that are already stored in the private hospital information system should then have a platform to follow, so that they can now submit data that is understood by the Ministry of Health, but without asking them to change their system. And that's why the principle was, let the private sector continue using the system that they're already using, but give them a platform where they can plug their current system, and that platform will transform the data into something that the Ministry of Health can understand. And that's why we ended up with the Philippine Health Information Exchange. It is basically a vision to engage the private sector in a national health information system. Before the Philippine Health Information Exchange, we had a split. We had the public health sector information system, and we did not know what was happening in the private sector information system. So rather than impose the public health software to the private sector, which is probably impossible, we just decided to just create that middleware, which is the Philippine Health Information Exchange.
Okay, the next question I'll pass on to Mohandan. Before I do that, does anybody have any questions? We can take a question from the audience if you guys are so inclined. All right. Does anybody have a mic? Can we give him a mic?
Okay, this in line with what Professor and Mohun said. Now, our population is aging, and we see a lot of non-communicable diseases, rising up, diabetics to hypertension to whatever it is. So, the indication is like going forward, we'll have a thumping health bill. Okay, someone has to bear it. So, coming back to you, the innovation. So, shouldn't be like, we keep on talking about, putting technology and, in healthcare. So we need to be, one thing is mindful that, it will health cost.
The institutional innovation is not there. Yeah, the governments are typically not geared to tendering for open source systems because, they have a different system of tendering for proprietary systems. So we fail because we are not able to get the institutional innovation in place. Yeah. So he gives examples of, say, Grameen Bank or the rickshaw pullers in the electrical rickshaw pullers in India, and how it had a with Grameen Bank, for example, there was a different way of banking, the different kinds of technologies. Then socially, it was reaching out to a different population than the people who didn't have collaterals, etc. So it was the intersection of these three which brought about the innovation and got benefits to more people.
Just to add a couple of comments of ground realities. Now, one thing is we have to appreciate that we have a national health service as opposed to insurance-driven healthcare service. So, so as a result of that, people expect everything and anything to be provided in the National Health Service, and nobody talks about the upper cap of what that figure is going to be. So that the issue is there is no accountability in terms of the cost. No meaning very little accountability in terms of the cost, because one clinician in one ward can be ordering the most expensive medicine, and the hospital will just provide that medicine, whereas the physician in the other ward may be prescribing rationally and not ordering the expensive medicine, and nobody would question why one against the other. Why is it so? Whereas it's not the same in another national health service which you have in the UK, where the National Center for Clinical Excellence would say this is what you can prescribe, and therefore everybody has to conform to that. And so we lack in that accountability, evidence-based medicine practice accountability issue. And it's only very recently that the Ministry of Health set up what they call the Quality Secretariat, looking at the quality issues. So all along what we have been doing is clearing the crowds, and you saw that in the OPDs that were portrayed today. We were clearing crowds, and we still intend to do that. But then you go to the private sector, and the private sector, it's out of pocket. It's not, again, insurance. So the private sector operators can demand anything. And now, actually, I'm sure you would agree with me when I say that if you go to the private sector OPDs or the channeling services, what they are doing is also clearing crowd, and people are paying for that. So the government is not paying. People are, although people make a hue and cry about it, there's no accountability there as well. The same thing is there. So who can bring in accountability? I mean, this is up for argument, but I would say that it's when this whole thing changes from either government paying or the individual paying to insurance paying. Because insurance is not going to reimburse everything and anything. Insurance companies would demand to know what they are paid for. And I know, for example, my friends who run hospitals in the US, they say their reimbursement rates by US insurance sometimes can be as low as 25 to 30%. So of what they actually bill the insurer, because they demand better quality of service. I was at the Comprehensive Cancer Center in University of Alabama at Birmingham last year, and they took me on a tour of the facility and took to a little room. They said this is a team funded by Medicare, and I asked them, what are they doing? They are working on bringing down the costs of working on models of bringing down the cost of health, of what the insurers would have to pay. So their remit was they get $1 million every year for 5 years, but they have to come up with models which will save Medicare $50 million. So that was the remit. So see, so we have this accountability issue, all around, and I think the fact that our insurance is only critical care insurance, serving I think 5% of the population or less, is also adding to that reason why we are failing to innovate, as it were. And you're quite right with the observation that in terms of ICT adoption, I think private sector in Sri Lanka is lagging behind, totally lagging behind. They just want to have their accounting system and the stock system in place. That's all.
All right. Does anybody else want to comment on that or ask a question about what was just said?
We've actually, I think, worked in a couple of private hospitals as well. So we've gone up to computerizing every detail and almost paperless administration, including clinical administration in the private hospital sector. What lacking is there's no common grounds or for us to share information. If I give a couple of few examples, like if we want a simple MRI to be reported by a radiologist, we need to have a courier send it to a government hospital where he or she is located or the residence, and then get it reported, bring it back and hand it over. So there's the issue of cost, effectiveness, efficiency, all that. Because one thing, there's a time delay, so the efficiency is low, I mean, because you need accurate information quite fast to make decisions. And also at the same time, like it's unnecessary cost. So who's going to pay for it, as he asked? Ultimately, we have to charge from the patient. But if there's a central information sharing base, I think all these things can be avoided. So the advantage ultimately is going to the patient, not only from the cost factor of it, but even the efficiency factor. Now, another example, a simple lab report. Like most of the patients don't keep their records, in their files unless like they have like very routine way of going to a doctor on some chronic issue. So simply we'll have to order the test again. But if there's a central base, you give the ID number or something like that, retrieve information, so you don't need to repeat those unnecessary investigations. Again, it goes to the patient. There's an issue of efficiency and effectiveness because it takes more time so the decision is delayed. So all these problems comes up. I think what we need is some infrastructure, some regulatory body coming up in between to share this information, but we have information in our fingertips. The problem is we have no way of sharing it with other partners, including the government.
Okay, for convenience sake, I'm going to take that, and let's assume that the private sector is also up to par with the public sector, and the issue is interoperability or people talking to each other. Okay, so Pradeep is going to say.
I'll comment on that. You said there is no regulatory body, but there is actually a private sector regulatory council which can look into your aspect, this information sharing, and they can develop a model for you all.
For the moment, and maybe you guys can talk after and see whether you can put in touch with who needs to be talked about. So the next question I'm going to put forward, unless there's any other on a different topic from the audience. Anything? Okay.
I think one aspect that has not been looked into is the human resource aspect. Most of the, as Professor Sai said, doctors who have done biomedical informatics now actually are doing pure IT stuff. That is because there is no pure IT guy in the hospital. If you don't have a pure IT guy, somebody has to do that. Without that, nothing will survive. So what we have to do, Dr. Champika Vikramsinghe, the Director Information, she is sending people to Moratu University to get certified, Cisco certified network qualifications. But thing is, we are sending minor staff because we don't have a permanent staff for IT. And when they go for that, they can't get certified because the exam is in English, and most of them don't understand English. So that's one issue. And the other thing is the health ecosystem. It's actually two large trade unions are in the health sector: the nursing union and the doctors. So sometimes when these issues come, when we implement systems, what we try to do is identify the most conducive environment and then slowly go implementing, making them feel like it is their project that they are implementing rather than something that we have forced upon them. If we force upon them, we might end up antagonizing them and having problems.
I'm going to stop you there for a second. Maybe you can respond to the first part and leave the
So your point is absolutely right, and this is why institutions need to focus on their core, and they need to go to the respective partners to adopt that particular model. So the cabinet has approved 3 weeks ago a cross-government platform and a network which would be done across. So that's the government cloud and the government connectivity network. This includes 3,500 state institutions, including the hospitals, to be connected and completely with Wi-Fi access. So you don't have this technical normal cables being plugged and all that. So it would be devices like notebooks and all that getting connected. So and the speeds at 100 Mbps. So those are the type of things that would, and the government network and the government cloud will come in. So these type of issues are taken away, and then you just focus on the application and get things moving.
So I'd like to also comment on that. Professor Sandeep was talking about hardware falling behind software in a lot of scenarios. You were talking about it during your big data session, that maybe hardware was not always a big priority to the donors, and they would focus on the software but didn't always focus on the hardware. What assurance do we have that this part of it is being focused on as well?
So the government cloud is actually right now, the government cloud includes two components, which is now going to be deployed somewhere February, March actually. And that has, one is the complete virtualized computing resource platform, and the other is the big data analytics. And the government has gone in for a 1 petabyte big data storage to start off with, and 35 data nodes, which is actually coming, and this will be used cross-government. Now, it doesn't matter how citizens interact with that, because 3,500 locations are going to be connected to that. So you can have your application there and have the whole of hospitals using it. So there's there's no requirement for institutions to start thinking, how am I going to build my network? How am I going to buy these servers? Those are all been taken, and Cabinet has approved it, and there's an interministerial committee that has been set up under the ICTA Act to ensure directives are given cross-government, and that area is completely cleared away.
Would you like to ask a question about that, Professor?
No, I think it's fantastic if that's being done, because I think it's really necessary to have that kind. Our experience, however, in India, working with the government is on the cloud thing is they get in a lot of regulations. Yeah. So, for example, we are supporting the application. They will restrict access to the application. Okay, we'll only give you access through one port, etc., which means you have to be physically sitting in one machine to be able to provide the remote support, which is sometimes we need the core team from Oslo to be looking at the application. That's one. The other problem we have is they ask for security certification for the application. So now like with the DHIS, we are getting a new version every 3 months. Yeah. So if we are making any upgrades, yeah, they will ask us to come back with a new certificate. And to get a new certificate, it takes 6-7 lakh rupees to pay to the government to do the testing. It takes 6 months to do the test. So while the physical environment is there, the policies, the regulations are a little suffocating to be able to enable innovation.
So I'm going to ask Pradeep a question, because I've been waiting for a while myself. Does anybody else want to comment on that before we move forward?
No, I'm okay.
No? Okay. All right. So I'm going to ask him a question. We have about half an hour left in this session, so we're only going to ask about 6 or 7 questions before it's done. So please start thinking about your questions now, because we might not have much time. Pradeep, I wanted to ask you, just quoting Professor Sandeep earlier, he was talking about Himachal and them using a hospital to get the data and then aggregating it and putting it in the cloud to use for different things. Why can't we do something like that, where even the aggregate data is available, and like ICTA has opened up for apps and stuff? Why can't we take it to that level?
Yeah, let me put some light into the current ground situation. Actually, in Sri Lanka, the curative or the hospital-based care is as we discussed, is private sector and government sector. But the whole of preventive care is only through the government sector. And the maternal and child health activities, the programs which go on, and all those data which get accumulated are currently through paper-based systems and are reported to the central level. But I must say that the government curative care, the hospital-based care, the main reporting mechanism is the IMMR, which is the Indo, that is inpatient morbidity and mortality report, which is now getting the aggregated data through electronic format. And within 2017, I'm 100% sure that we are going to cover the whole of the island. So the aggregated data is currently being collected, and it's real time for the curative sector. So we are actually thinking of and drilling down to do the same thing for the preventive sector.
Maybe just to add, I think the way from what I gathered here, the different hospitals are sort of going their own way in terms of the platforms, the metadata, etc. And given that, I think it'll be very difficult to do this aggregation, because you would like it to be much more standardized and structured. I think Alvin had a problem in Philippines. They were running, the different clinics were running electronic health records, but they were on different databases, different platforms. So when they wanted to get it to a national level, they could not because of the non-standardized thing. So I think it's important, to check in early to get these standardizations right.
So if I may put it blunt, actually today, with the whole web scale architecture and all that, standardization is is also questioned because of innovation as we keep moving. And more search and more analytic tools which comes into Hadoop and big data analytics and all that. There could be reporting based on hashtagging, and there are many other ways in which. So I think the fact of very organized standard data tables, which used to be predominantly the way in which data sets used to be done, is actually not needed to that extent. We can actually right now start opening the doors for a little bit of innovation in the whole sector. We can do that. And that might be also good, because then you bring in that innovation sector, because once you standardize, you need to make sure every time you're looking at these whole things and keep trying to modify version after version. So that might also be restricting innovation. But I think more than, if the data keeps flowing, today you look at the whole web space, you have Facebook, you have Google, you have all these guys, and they keep coming, but you still can access data from that. And they have their own standards of things, and still you can access. You want to search, you can get the search results. But so I think it's more than the standardization that I would say is that first get the data in to a central place, have the analytic tools, and then people would make their data more meaningful. I think that might be the way to actually take it, because we need to allow the hospitals also to have the free will, and like the private hospitals will want to do what they want to do as well.
Yeah, I mean, standardization could be simply getting your nomenclature right. When you're measuring the same disease across hospitals, it should have the same name, and that is often not the case. The other problem, I think, with the analytics is the ministries of health are very poor. Their capacities to do even simple analysis. I mean, we've been struggling with that last 3 decades. To be able to get them to look at graphs and charts and things like that. And India, they have adopted SaaS. I mean, paying millions of dollars for that, and you don't have more than a couple of users in the whole country. And so I think that's another challenge. So I think in the future, the focus on building skills for analysis of the kind which you're talking about when we're talking of big data, I think is a priority.
Yeah. Can we give a mic to the back?
Thank you very much for very interesting discussion. A couple of points actually, just picking up on the last one, regarding the ministries and the state sector sometimes not being very good with analytics and using the data. I think when we gather data, we should very proactively make the data usable, make it usable very immediately, as businesses do, as opposed to making the data available and usable months and years later. And I think lots of people have very good ideas in the health sector how that can be done, and I'm sure that's one of the ways to actually use the data which you gather, in which case it doesn't become historic, it gets shared already. The second thing I wanted to say was I'm not from the ICTA, but just reflecting Professor Sandeep's comment about the state ICT agencies sometimes not being very helpful. I must say with the ICTA, we've had amazingly positive experience. They've been amazingly helpful. We run this ICU surveillance thing on behalf of the ministry. And every time we've had an iteration or a modification or a ground-based need, we found them to be amazingly receptive. So I hope they keep up the good work. Thank you.
Thank you. Thanks. Can I was just thinking whether I would just ask a question from somebody in the audience, Dr. Arjuna Vijayakon, because you've been spearheading ICT work in the Northwestern province, and as somebody coming from the provinces, is there, because in Sri Lanka health is a devolved subject, so you do run a lot of operations there. Are there any comments that you would like to add to this discussion in terms of what are the ground realities you face?
Yes, I would like to add that the basic difference when Colombo is compared to where I work, the northwestern province or the Kurunegala district, is actually the infrastructure is totally different. I mean, the physical infrastructure, the network infrastructure, and human resource, everything. So, after my master's in biomedical informatics, I worked for some time in the ministry and then got transferred my proper appointment to the to Northwestern province. So I had a lot of plans, but when I am there, I realize that lot of groundwork is needed to be done for me to start the real work I intended to do. It like to give a simple example, uh, we were talking about universal data connectivity, but there I realized we had 218 healthcare institutions for the provincial department. Out of those, 90 not even had a simple telephone line. That is 4 years back. So I had to start from that level. Now we have achieved 100% voice connectivity and about 70 to 80% data connectivity. So we have started giving basic ICT training for our staff as a routine. We train 10 staff members per week on basic ICT operations. So I think now we have come to a stage that we are ready to receive or say to test or implement a real ICT solution. So I think there are a lot of systems that we tried to implement but failed in the sense that we failed to sustain or we failed to replicate it. That is because when planning from Colombo, we have not understood the real ground scenario there. So I realized it because I started working there. So my request, my humble request is to plan anything, come to the real place that the things will be implemented, study it, identify the need, and then come with the solution. It will be real successful.
To put it another way, Moon, then the cloud is fine, but how do we know that they can use it once it's there?
So, let's give you a good answer. If you have this problem by the end of 2016, I quit my job. Right? We're basically bringing in Google Loon across for whole national infrastructure connectivity, so all the telcos can use that. So that would be covering the entire country for high-speed connectivity. We guarantee that all your 200 hospitals will be connected with 100 Mbps connections soon. And the cloud platform will be available for your access within government. And that's the type of infrastructure that we're talking about, what we call under the Ministry of Digital Infrastructure, ICTA wants to take forward. And in order to move this fast is what the Interministerial Committee has been put, and it's with 7 ministers, and actually five of them are cabinet ministers inside, including the Minister for Finance is also a part of that whole thing. It's to drive it and to make sure that this whole rollout takes place, and thereafter you have the right to deploy any applications there, so you don't have a problem with replication, you don't have a problem with accessibility, connectivity, but just focus on your internal resources who just could use applications very basically to do their work and move forward. That's what we could, and we'll give you the big data analytics also as a platform for you to do analytics on top of it.
What about the people? Like he mentioned that the people has to also be trained. What
Yeah,
about
so
that side?
Now, if you look, when you say traditionally when you took IT and people training, you used to look at networking, you looked at the operating system and all that. But today with tabs and all that, you just have your app and you switch it on, and then you go into your app and do your specific work. So it's very similar to actually using the mobile phone, a smartphone, and those are the type of apps that needs to be given. So the training could be very limited in terms of information technology. Now I totally understand his problem. Being here, having people to do the networking, having all this all the connectivity and all that could be done because the resources are available. But what we're trying to do is make it very simple. It's completely Wi-Fi brought in, connectivity given. You don't have to bother. The telcos will take care of it. You just have your you have a tablet and make sure your application is there, or have a notebook and application is there, and just focus on the application, and which should be cloud based, so that you have web access. So through the browser you access it, so there's no install and any of those functionality that is required on the ground.
Mundan, you just went on Facebook, and our social media guys are highlighting you.
Please.
So
I guess we'll take it up. I think there must be commitment, and you know, this is the drive ICTA wants to take forward, and we have that commitment at ICTA to achieve that status.
Yeah, I mean, I would like to echo what Dr. Hanifa mentioned earlier. That was that, you know, all along the way, ICTA has been very facilitating in terms of a lot of things that we did as well. I'd like to also ask a question from Indika D'Souza, the country manager for Intel. I'm putting him on the spot because he's a guy who worked with us a lot in the past. I came to me today and said, let's start working together again. He had a few disappointments of getting things off the ground in the regions. Indika, any ideas you want to share with us?
Yeah. So as Prof said, like, you know, we tried getting connectivity into, like, you know, rural hospitals like 4-5 years ago, and actually we went up to the United Nations and country did a pledge that that was 4 years ago, I think 5 years ago, that we are going to train the healthcare force on ICT. I think now that paradigm is, I mean, it's changed, because as Gundan said, there's no need of, like, you know, traditional IT training is required. It's about applications. You learn about it and you get on with it. And even you want to learn, like, you know, the device will provide you the basic training, but is you need to get in it. So probably one of the things, like, coming from the private sector, as well as, like, you know, talking about the Silicon Valley, about its development, which is as Intel as a corporation, which is coming in from that side. We have a lot of devices basically coming in today. Most of them are like plug and play. Most of the USB provided devices, like in your digital blood pressure meters, to whatever the devices what you use in the healthcare sector, which is accessibility is getting, like, you know, more of things. And also the newest trend, what is we're talking about, the Internet of Things, IoT, whereas the silicon is getting into the clothing, which will, end of the day, measure your blood pressure, whether your cholesterol level, what is your food intake, what you took, how much of calories you took, which is give analysis on your in the data center, whereas, like, you know, what is the, or how much of calories you want to burn in the gym when you go in the gym in the evening. So this is where the world is actually heading in. So I think today one of the good examples was, like, you know, we saw the health minister and the digital infrastructure minister in the same podium talking about it. I think I saw it in the first time, if I'm not mistaken, that both of them are talking about the same message. I think that it gives a message to us. What Bundan was, I think, the background was the like, you know, ministerial task force which has been set up. I think all this is good. Like, you know, we have the commitment from the government as well as from the ministry as well. And also the national cloud data center coming in, all this is actually need to be plugged in. Our life becomes, like, you know, how implementation will become easy, as the doctor said, like, you know, how in the rural areas, how the things will be difficult, or what exactly it's been. Actually, the most of the services are required in rural areas. Actually, I think we went up to Jaffna some time back to talking about digital or non-Eastern province. So we saw how it is being done. I think the right platform is being created. So I think I'm really pleased to see, like, you know, seeing involved with the health sector with Professor Vajra and the team on seeing how this can be taken. We had a lot of fallbacks as well, but I think we can do a fresh start, get on with it. And also one question I was running in my mind, like, you know, probably Mundan can answer this, like, as well, like, you know, we have basically software companies in the country. Like, you know, we go up to the level of managing the London Stock Exchange. We have state-of-the-art designing guys in Sri Lanka. And when I saw the Dr. Mahipala's presentation in the morning, we have been piloting many other things from, like, back in 2000, or, like, you know, far beyond that. But most of the things are, like, you know, saying piloted, moved into few hospitals, nothing has scaled up to national level. So we have basically technologies here. We have the state-of-the-art designing capabilities from the industry, which we are looking at crossing about $1 billion exposed right now. And we have done so much of things. I think we have got decent amount of donor funding coming in right throughout, but it has not scaled up to the national level. There's something is missing at the policy level. I'm not quite sure the health policy or e-health policy, what you call it, is in place, or that can be part of the national policy which is now getting implemented. Do we have a gap, or we have a way on that?
So incubation, facilitation, you may call it accelerators now, is that we have people with the knowledge out there, and we have on the domain, and then you have technology people who actually can build this whole ecosystem. Traditionally, it used to cost a lot of money, as you know, but now it doesn't, and that's the way startups actually incubate. ICT has actually got quite a decent budget into the spiralation programs and all that, and we would actually take that whole aspect of spiralation to the next level. That's one. In terms of a national rollout, we've identified all our weaknesses and what was actually these bottlenecks, and we're clearing it off. So once it works in hospital A, it works in hospital B and hospital C. Then if it's not implemented in the fourth and the fifth, then of course it's not the problem with application. It's a problem on the ground which needs to be sorted out with regard to the human. So that's the type of things that we're doing. But in terms of software development, we have given a commitment that we want local software to be built so that there is continuity of support and people who can innovate with lots of local flavors added to it.
So I've seen, or like most of the applications. There are quite a bit of applications that have won like global awards as well. But one of the things is that these award-winning ones have not scaled up. They by the judging panel and also gone up to the Asian region or beyond that has not scaled up. Probably that is something we can need to think through. How do you scale up? And also there has been a tendency like who has been presented in these discussions are not encouraged. Or I've seen specifically from the ministry side like there's no encouragement of that. Like they have been, if we done for the MSc, they have been asked to stop. Like research paper is done, you are through your exam, park it.
So this is where I think we've done enough pilots. I think this country always talks about pilots. Start something, let's do a pilot, then get a study, get the report out. By the time you have the people have changed and the technology has changed. So either we start something today and we immediately go ahead, because I don't think it's rocket science and people are ready to accept it, and we just go ahead and implement it. Version 2 of that application will actually cover certain of those drawbacks. But we are at the stage of digital evolution and we need to push that forward. So we have taken this whole fact of, let's do a pilot, let's do this study report, come out with a report, let's try to find the fault. Let's just clean it off. You start something today, finish it in 6 months. And that's exactly what we need to do.
Before we go to Dr. Hanifa, can I we've been talking about the health systems, but we also have the president of the Independent Medical Practitioners Association here. So the independent medical practitioners are doctors who are out there practicing alone. Dr. Hasari, you've been listening all day from morning. I'm going to ask you to say a few words and share your thoughts with us.
Actually, thank you for giving me the offer of saying a few words. Actually, I'm very much interested in e-technology going forward, because I'm a GP for the last 30 years, and I found that a lot of patients are using these high-tech solutions to come forward. You get the two sectors, one sector who are not capable of using and the other sector who are capable of using. And unfortunately, the people who are using the technology are coming out with wrong ideas. They come with wrong things. So I think we have to get a lot of messages through. That's my personal view, practicing 30 years.
Okay, thank you, and Doctor. Yeah. Okay.
Sorry, I won't take long, just 1 minute actually. I just wanted to, against my better judgment, I just want to say something about the Swabhimani. And the National Intensive Care Surveillance was proud to win the eHealth Award for last year. And to be honest, we are not a pilot. Our system runs in more than 100 ICUs across the country, has more than 80,000 bed reports, has more than 20,000 admission patient records, which is unprecedented in a low middle income country in a critical care setting. And we do all the analytics, reporting, etc. So ours is not a pilot, and we haven't been damaged by the curse of Swabhimani. That's what you want to call it. And thank you very much. And that's because of all the support we get from the Ministry of Health, lots of people working hard at the ICTA and lots of the other colleges and the ICUs and the hospitals. So hopefully we can prove them wrong. Thank you very much.
Okay. I'm going to take one more question and then I'm going to pass it on to all the panelists for 1 minute closing remarks. So get ready for that. And one more question. Bottom left-hand side.
This question is for Professor Sandeep. Now, with all these new innovations and new technology coming in, now you said that the biomedical informatics, health informaticians, that you also contributed in developing. Now, what do you see their future as? How do you place them in our health system? What is the role they have?
I mean, primarily, I would say that there is a lot of data on flow. How do we use the data to improve health outcomes? You know, I see a real strong role the bioinformatics graduates to be playing in the use of information to improve health outcomes. That's one. And second is designing better systems in being able to provide relevant inputs like what Doctor just said. You know, people with good ideas contributing to good design.
So, right, we're going to stop taking questions. Okay, there's one more. Okay, we'll take one more question. A bit brief, please.
Everybody is speaking about the centralized location for the information, like patient history and patient digitalized information for the patient. So my question for the ICTA is, anybody propose the kind of a solution at the moment, or if the private sector is proposing, what are the steps they need to follow?
So, if you ask me, we've already come to the point of awarding. So we've advertised, all done. The 3,500 links, the government cloud, everything's done by standards, and it is all the telcos bidded for it as well. So it's all done in terms of all international standards, ensuring security and all that. So it is just not the private. This has to be an ecosystem. It's not about one vendor. No, that's not how it works. It's about different providers who come to give different technologies. So when you look at it by the Act, so we internally worked with our technical teams and we came up with a drive for that whole part.
Maybe I can clarify this. He's saying there is a system in place and people have to get involved and put everything, because the private sector and public sector still have to interact, but there is a network in place.
So the private sector will be a part of this whole ecosystem. It's not to demarcate, this is for government, this is for things. If you look at all 3,500 sites which are going with connectivity, there is Wi-Fi access. Even private applications will go to those locations, and citizens can actually use those applications. So we're not just looking at the network. If we have a network to the hospital, we're just not looking at it only from the health perspective. Might be you want to make payment for some other services. You can do it at that same point. So we're actually building this ecosystem for everyone to come and plug in themselves.
Okay, one more final question. There is a question that's come in via the web, which I think we should take because it's the Digital Health Forum. Professor Tony Sahama from WebEx. The question he asks is, when and how do patient and does patient and professional awareness take place? Anybody can comment on this, I guess. Yeah, he says, when and how does patient and professional awareness take place within the system? It's a fairly open question. If you can comment on it, I think it might be helpful.
As early as possible, because they're the major stakeholders of the system, especially the patient. Then it's good to have this socialization of whatever is going to be built, is going to be shared, is going to be exchanged. In the Philippines, what we did when we've gotten a lot of input coming from the people, and we're basically inclined towards the data protection directive of the European Union.
Mundan, if I can ask you a question related to that as well. Are you planning something like this before this, opening up to the public before we go on to your 2016 connectivity?
So one of the main things is about, if you looked in the last Manila diaries and all that, and taking that whole drive, the digital drive there. But to the question specifically, I think it's just that you build the ecosystem, allow the market forces to take it. That's just the way to go ahead. We can just, yeah, okay.
Again, I think maybe India is different in terms of with the electronic medical record work which we are doing. What we realized was the patients, because they historically have not got information, they did not know they had to demand for the information. Maybe also issues relating to literacy, etc. So we were going around in the hospitals and telling them, you must ask the doctor for the printout. It's your right to ask for it, and if you get it now, 5 years later you'll be able to give better health to your child. And so what we found, because they have been historically disempowered, they do not realize that they have the possibility of asking for that. So building that sense of you have that choice. I think
right.
Yeah.
Okay, so I'm basically going to close the session and pass it along to all the panelists for final remarks, maybe a few seconds, anything you want to say, and then we'll close the session afterwards.
I think you've said a lot.
You said a lot. Okay. So Alvin, maybe you want to start because
yes. So as I said, combining two complex domains like IT and health is a formula for disaster. So you need governance to manage that complexity, and the governance will then empower the architecture as to how the business of healthcare and the business of IT will be put together to deliver better value to the citizens. So I'm like a broken record player: strategy, governance, and architecture.
Yes, as we discussed a whole lot, I think as a one final comment, I would like to comment on the pilot issues of innovations. As financially, organizationally feasible, then of course we won't go and knock ourselves on the wall after piloting.
Well, on the pilots, as some of you may know, I have a mission that is eradication of pilot-itis from Sri Lanka. I've written on that in the press as well, because that's an endemic problem and we need to get over that. And I think the discussion today is towards focused on that, and I'm very happy about it. But my final comment that I wanted to tell you is that when we put together this round table, as it were, the organizing committee asked me, you're going to put this from 5 o'clock to 7 o'clock. Who is going to be there? Because no doctor stays on after 5 o'clock. And today, I think I've been with an audience of about 100 people here, and I still don't get any body signals of anybody wanting to get up and go. So I think that's the body signal that I'm getting from here. So I think it's I'm really happy that we put this together because I think we can come up with a set of recommendations based on these discussions which we can take forward, and let's try to do that. Thank you very much, but I'll pass on to the other panelists.
My closing comments would be think big, be inclusive, and think of citizens as a citizen-centric service rather than just thinking of domain-related service, and just look into a digitally inclusive society and join us on this whole wave of creating a digital revolution in Sri Lanka. Thank you.
There was a question on how do you bring down the cost of the application and how do you incentivize the innovation. We have a couple of proven examples, even from the dialogue. How if dialogue pay for the mobile application, how much it would cost. What they have done is they have built an ecosystem of having app store and giving the developer the tools. So developer made the innovation. Likewise, once we connect 300 hospitals, and once we laid all this digital infrastructure, it won't be a big matter, big thing of the cost. And there will be a lot of innovative people, especially the bioinformatics graduates here, the second largest population in the world, right, to do the innovation and to bring the cost down of the all application in the health domain. Thank you.
What I hear all around is I think people are ready for digital health. Because from the public sector and the private sector and everybody around, from the ethic makers, the policy makers, everybody, I think they are getting ready. And if we are not fully ready, at least we are getting there. And the thing is, there's few more things to do. And in digital health, I think, as our company goes as well, we are here, and we actually our goal would be to bring down cost in support you on medical health systems, as well as maybe people to own their own patients, empower the patients, and reduce optimize drug utilization and things like better manage the doctors and the nurses' time. So there's a lot of apps out there, as Mohan was saying. They have put the structure in place, the infrastructure in place, so the people with apps, people with systems can come and build on it. So I think what I hear all around, I think most of the stakeholders are here. They are ready for a digital health era. So I think we have come out at the right time. Thank you.
It just paused. It just paused me now to just close the session off, and it's 7:03, so we keep you too long. Basically, I think maybe I'll pass it on to Professor. You want to invite him to cocktails or something like that, Professor?
So, I would like to thank Jagdish for having this session with me, and I think he'll have a lot to write in the paper over the weekend and on next month's column. Yeah. Again, as I said, before at 3 o'clock, I told the hotel, be ready for cocktails at 6. I didn't think that this conversation would be so exciting, and there'll be so much to talk. And they were ready at 6. I could see from here, but the last thing that I have to tell you is, please join us for cocktails outside, and we'll see you again tomorrow morning. Thank you.